Okay, so these areas they are concentrated. So we'll start our topic from our newborn and care of newborn. So in care of newborn, we'll start with the neonatal resuscitation. So almost 90% of the newborn babies. So most of these things will be in numbers and a few terminology. Most of the things will be of one-liners. So we have to remember those things. So almost 90% of the newborn babies will not require any assistance at birth, and only 10% of the baby needs some assistance, some suctioning or some amount of oxygen. So these are required only by 10% of babies, and only less than 1% of babies need extensive resuscitation like CPR, bag and mask ventilation, or giving IV adrenaline. All these things are required by less than 1%. So all these numbers we have to remember. And this is one of the important chart, what things we have to do at resuscitation. So in this actually, yeah. So the first steps what we have to do is, remember it as first when we receive the baby, we have to position the baby. T-E-S-S-R you have to remember. So first we have to position the baby in a way that the airway has to be kept open. So that is the snipping position like we intubate, no? So the same position we have to keep. Next we have to dry the baby. The drying we should do in head first because it is of large surface area. The next thing is we have to do suction. So this suction we'll do in mouth first, followed by nose. So why? Because if there is any secretions in the mouth, it may get aspirate. So first we have to clear the mouth, then we have to go for the nose. So position, drying, suctioning, followed by stimulation. If the baby is not crying, we have to tap the sole or rub the back. And last, we have to reposition the baby. So in all these steps, our position may go up. So this is the basic requirement for all the baby. If the baby is crying fine also, we have to do this initial steps. So 90% of the baby will come in this, and remaining 10% requires some assistance. We have to give oxygen, or we may need a positive pressure ventilation. And these intubation, chest compressions, and IV medications are rarely needed by the newborn babies of only 10%. So we have to ask 3 questions when we are receiving a baby. One is the baby is term or not. Second is the baby is breathing or crying. Third is what is the tone? It is good tone or floppy baby. So if the answer to all these 3 questions is yes, we have to give it to the mother side. The baby is completely fine. So if there is no, we have to start our resuscitation. So this is the newborn resuscitation protocol. So what I said, this position, drying, suctioning, stimulation, all these things will come in the initial step. So these initial steps invariably will do for all the baby. If the baby is crying or not crying, we have to do all these steps. The initial steps we have to do in 30 seconds. So this number is important again. All these steps we have to do in 30 seconds, followed by if the baby is not crying or if the heart rate is less than 100. So we have to start the positive pressure ventilation with the bag and mask. Bag and mask ventilation we have to do for next 30 seconds. So this 30 seconds plus next 30 seconds is called as the first golden minute of resuscitation. So this is the first golden minute of resuscitation. So even after 1 minute, if the baby is not crying after 1 minute, what we have to do is we have to do a ventilation corrective steps. The corrective steps we have to remember as MRSOPA, Mr. SOPA. So this M stands for mask repositioning. We have to reposition the bag and mask. R stands for, so M stands for the mask reposition. R stands for repositioning of the baby. We have to reposition the baby in a way that the airway is open. So S is suctioning, O is we have to connect to oxygen, and P is we have to increase the positive pressure ventilation. We have to increase the pressure in the bag what we are giving. So on A is we have to consider for alternate airway, that is intubation. So these ventilation corrective steps we have to do, and we have to continue our bag and mask for next 30 minutes. So here completes the 1.5 minutes. 1.5 minutes, here it will get complete. And next, even after 1.5 minutes, if the baby is not crying or breathing, we have to consider for intubation, and we have to start our chest compression for next 30 seconds. We have to do chest compressions for next 30 seconds. And still, if the heart rate is less than 60 beats per minute at 2 minutes. At 2 minutes, we have to give the IV adrenaline. So this is the very basic neonatal resuscitation protocol we have to know. So the few things we have to remember in this is positive pressure ventilation, chest compressions, and epinephrine. So positive pressure ventilation, we all know. What is the indication for positive pressure ventilation is if the baby is apneic or not, or gasping, if the baby is gasping, or if the heart rate is less than 100. So this is the indication for positive pressure ventilation. What all methods we can give positive pressure ventilation? One, the common thing what we use is bag and mask ventilation. It is self-inflating bag. So if you press the bag, it will inflate on its own. The second is flow inflating bag. And third one is CPAP, that is continuous positive airway pressure we can give in the delivery room itself. So these are all the things we can, these are all the methods of positive pressure ventilation we can use. So how many times we have to, the common thing what we use is bag and mask ventilation. The common thing what we use is bag and mask ventilation. So how many times we have to press the bag? So we have to give 40 to 60 breaths. So normal respiratory rate of a newborn baby is 40 to 60. So we have to give 40 to 60 breaths per minute. So that is the compression of the bag. And disadvantage here is there is a chances of getting air in the stomach. The air may go into the esophagus and stomach may get inflated, and that may obstruct the respiration of the baby also. So we have to decompress the air in the stomach when you are doing positive pressure ventilation. So second thing is chest compression. So chest compression, we have two methods here shown in this picture. It is 2-finger technique. We can keep 2 fingers in the center of the chest. We will do compression. The second thing is we can do 2-thumb technique. So we can encircle the chest of the baby and start doing the compressions. Okay. So if we are a single resuscitator for a baby, we can use 2-finger technique because our one more hand will be giving bag and mask. If there are 2 rescuers, go for the 2-thumb technique. The preferable technique is 2-thumb technique. So indication for chest compression is failed bag and mask. Failed bag and mask ventilation of heart rate less than 100. So even after bag and mask ventilation, the heart rate is 100, we have to start the chest compression. So the method we know, 2-finger technique and thumb technique. So number of times, again, we have to do 90 compressions per minute. Number of compressions is 90 compressions per minute. Disadvantage here is there is a chance of getting trauma when you are giving CPR. Okay. So this question they will ask, what is the compression ventilation ratio they will ask. So if you are giving both positive pressure ventilation, both bag and mask and chest compressions, we will do in a ratio of, for each 3 compressions, we will give 1 breath. For each 3 compressions, we will give 1 breath, which corresponds to almost 90 compressions and 30 breaths. 90 compressions and 30 breaths. This will give, so there sometimes they may ask total number of events in 1 minute. So the total number of events in 1 minute, sorry. The total number of events in 1 minute is 120 events. So these numbers again is important. 3 compressions. For each 3 compressions, we have to give 1 breath. In 1 minute, it is 90 compressions and 30 breaths. The total events is 120. So the third thing is, sorry, somebody wants to ask something?
No,
okay.
sir.
So can you please mute? You can put a text in chat if you want to ask something. So the third thing is epinephrine, and epinephrine. The third thing is epinephrine. Epinephrine will give the indication for epinephrine again is failed chest compressions. Failed chest compressions. Even after chest compressions, if there is no heart rate, if the heart rate is still less than 60, we can give epinephrine. We can give epinephrine in central line. Central line here is UVC, umbilical vein. Umbilical vein we can give epinephrine. And the second thing is intratracheal. We can give intratracheal epinephrine also. So what is the dose? The available adrenaline is 1 in 1000. So we have to dilute it to 1 in 10,000. And this 1 in 10,000 only we are using in newborn babies. If you are giving in UVC, umbilical vein central line, we have to give 0.1 to 0.3 ml per kg of adrenaline. If you are giving in trachea, we can give 0.5 to 1 ml of per kg of adrenaline. So this thing we have to remember. So these numbers again we have to remember. So this finishes the basic of positive pressure ventilation, chest compressions, and epinephrine. So the second important topic here is Apgar score. We all will be knowing. Can we use Apgar score as a guide for resuscitation? The answer is no, because we'll start measuring Apgar from 1 minute of birth. We are starting our resuscitation in 0 minute of the birth. So Apgar we can't use as a guide for resuscitation. Okay. So what are the components of Apgar score? This we all will be knowing, right? So A stands for appearance. That is for the mnemonic purpose. So A is the color. A is color. And P is pulse rate. That is heart rate. Excuse me, doctors. Can you please put your mic on mute so that it won't be disturbing others? Kindly mute your mic, no? Hello, yara irkingla? Okay. So A is appearance, color, P is pulse rate, that stands for heart rate, and G is grimace, that is the response to the catheter in the nostril. So if you put the catheter in the nostril, the baby will make a face, that is grimace. Okay. And the next A stands for activity, that is muscle tone of the baby. R is respiratory effort. It is not respiratory rate, it is respiratory effort of the baby. Again, we have to remember this, it is not respiratory rate, it is respiratory effort. So we have a total score of, we have a score of 2 for each and a total score of 10. So if the color is blue, the baby is completely blue, it is 0 score. If there is acrocyanosis is only the score is 1. There is, excuse me, Ismail, can you please mute your mic? Ismail, can you hear me? Ismail. Okay, so 2 stands for a pink baby. If the baby is completely pink, we will give a score of 2. So pulse rate, if there is no heart rate, it is 0. If the heart rate is less than 100, it will give a score of 1. If the heart rate is more than 100, will give a score of 2. So grimace, again, I have told grimace is if you are putting a catheter in the nose, the baby will make an abnormal face. That is grimace. If the baby is making that grimace, will give a score of 1 for grimace. Normally, the baby will sneeze. Or cough if the baby is fine. So we'll give a score 2. And if there is no response, we'll give a score of 0. So activity, if the baby is moving all 4 limbs, good, active, it is the score of 2. If there is only peripheral, if there is only the peripheral flexion, only a partial flexion of the peripheries is there, that is the score of 1. If it is a limp baby, completely floppy limp baby, will give a score of 0. Again, respiratory effort, the baby will breathe normally or there will be a good cry. If there is a good cry, it is a good respiratory effort, right? So we'll give a score of 2. If there is irregular breathing or slow breathing, will give a score of 1. So if there is no breathing, we'll give a score of 0. So the total score is, if all are normal, the total score is 10. Okay. So when to measure this Apgar score? We have to measure this Apgar score at, normally we'll measure at 1 minute and 5 minutes of birth. We'll measure Apgar at 1 minute and 5 minutes of birth. So if this 5 minutes Apgar score is less than 7, we have to measure Apgar score at 10 minutes, 15 minutes and 20 minutes also. So this is called as extended Apgar score. So this is called extended Apgar score. And how will we interpret this Apgar score? So if the Apgar score of 0 to 3, it is poor Apgar. So this poor Apgar means the baby is having severe asphyxia. It is severe asphyxiated
baby.
If it is 4 to 6, it is mild to moderate asphyxia. It is mild to moderate asphyxia. If the score is above 7, it is non-asphyxiated baby. It is normal baby. So this interpretation of the Apgar score we should be knowing. So the next thing, few important topics what we are going to see about is IUGR and preterm babies. So before that, we'll brush this very basic. So normal birth weight of a baby is 2.5 to 4 kgs. This we all will be knowing, 2.5 to 4 kgs. If it is less than 2.5 kg, low birth weight, less than 1.5 kg, very low birth weight, less than 1 kg is extremely low birth weight. So till here we all will be knowing. So these two are newer terminologies. Preemies are less than 750 grams and micro preemies are less than 500 grams. Preemies are less than 750 grams and micro preemies are less than 500 grams. And a big baby or large baby will be of more than 4 kg. So this is more than 4 kg. This is the weight-based classification of the babies. And what is the average weight of an Indian baby? That is, the answer is 2.8 kg. So the average weight of an Indian born baby is 2.8 kg. Okay. So the second classification is based on the gestational age. We all know the term baby is 37 completed weeks till 42 weeks. It is term baby. It corresponds to 259 to 293 days. Sometimes they may ask in days also. So 259 to 293 days is the term baby. So preterm babies is anything less than 37 weeks is preterm. In preterm itself, we have classification. Late preterm is 34 to 37 weeks. Early preterm is 28 to 34 weeks. And again, we have two newer terminologies. That is, extreme preterm is 26 and 27. Micro preterm is less than 26 weeks. So this is the preterm classification. And after term, the post dated is if the baby is delivered after the date of EDD. So EDD corresponds to how many weeks? EDD corresponds to how many weeks? Yara solam. Hello? Okay, no response. EDD corresponds to 40 weeks. EDD corresponds to 40 weeks. And EDD corresponds to 40 weeks. And the post term is after 42 weeks. Why this post term is after 42 weeks? Because the fertilization occurs. So this EDD we are calculating from LMP. So this is the last menstrual period. Let us take it as Jan 1. So this mother will be ovulating on her day of the cycle. So this is Jan 14. Under next period, let us consider it is 28 days cycle and the next period should be on 28 days. So the lifespan of ovum is 1 day, 24 to 48 hours. So the fertilization also should occur on 14th day, right? So we are calculating the age of the fetus from LMP. So these 14 days are empty. Here there is no ovulation itself. So these 14 days only we are taking here for the post-term babies. So this is the very basic of classification of based on age. And period of viability, baby is considered as viable after 22 weeks of gestation. It is considered as viable after 22 weeks of gestation. And MTP can be done till 20 weeks of gestation. So if the viability starts after 22 weeks, there is still discussions are going. We can consider MTP till 22 weeks. Okay. Right. So next, based on the gestation age of the fetus, we have USD. This is based on USD. So TRL is ground rump length, which is more reliable in the first.
Hello,
time.
madam.
Hello, Ashwin.
Madam. கேக்குது madam.
ஒன்னும் இல்ல சார், நாளைக்கு குட்டப்பட்ட ரவிதா மேம் செய்வாமா?
ஓ, ஓகே மேடம்.
நீங்க குட்டப்பட்ட
நாளைக்கு
உங்களை டியூட்டி போட்டோம்னு நினைச்சாங்க. அந்த நேரத்துல எனக்கு கால் பண்ணாங்க போல, எந்த ஷிஃப்ட்க்கு. ஆக்சுவலி எல்லாம் போன்ல தான் வரோம் அப்படின்னு.
Is it audible to everybody?
அதனால நீங்க அங்க போறதா? நான் சொன்னேன் மேம், எனக்கு நான் போயிட்டு ஆக்சுவலி வேட்டேரி வர சொல்லவா அப்படின்னு. இங்க ஸ்கேன் பார்க்கணுமாமா.
ஓ,
அதனால நீங்க அஸ்வினை குட்டப்பட்டி அஸ்வினியே போக சொல்லுங்க.
நாளைக்கு மேடம்.
ஆமா மேச்சேரி வந்து வேலை
அப்படிதான் மேடம் அதை பண்ணிக்க வேண்டியது.
எனக்கு இங்க ரொம்ப பக்கம் 7
kilometers of
எனக்கு இது தூரம் வேற.
I am not audible or
மாறணும்னு பார்த்தேன். இது
hearing
கேட்கவே நம்மளே
talking. I don't know who is this.
அப்படின்னு ஸ்கேன் இருக்கு தெரியாது ஒரு ஒருத்தர் கேட்டேன்.
சரி
சரிங்க
நாளைக்கு கூட்ட ஓகே.
ஆர்டிஸ்ட் மேகலா அமைச்சிருப்பாங்க, அவங்க இன்னைக்கு லீவ் எடுத்துக்கிட்டாங்க, சண்டே வந்ததுனால.
ஓ ஆமா அன்னைக்கு எதுவும் போயிருந்தாங்க இதுக்கு. ஆமாங்க.
What I should do? Please mute your call. Okay.
இவருங்க அது எப்ப வருவாருன்னு தெரியல. ஆர்டிஸ்ட்
I
மேல
don't think so. She is seeing the chat.
ரிலீவ்
ரிலீவ் பண்ணா இந்த பக்கம் ரிலீவ் பண்ண ஆரம்பிச்சிட்டாங்க போல. தூரலாம் 30 ஓட ரிலீவ் பண்ற மாதிரி சொன்னாங்க.
மேடம் யார் மேடம்
அப்படினா
பேசுறாங்க?
ரெண்டு
கிளாஸ்
நாள்
போயிட்டு
தான்.
மேடம்
அந்த 7 days எடுத்து.
Okay, I think she moved it.
Please mute your voice, sir.
Okay, now it's clear, I think. Sorry for okay. I don't know. So,
Yes, sir. Yes, sir.
this ground rump length is more reliable in the first trimester. The first trimester gestational age assessment, we can use ground rump length. The CHL is crown heel length. Okay. The second thing is BPD, that is biparietal diameter, which is more reliable in the second trimester. And third is femur length, which is more reliable in the third trimester. This again for the assessment of gestational age of the baby. And we have one more thing. Let us keep the baby as delivered, and we don't know the LMP or EDD or scans anything. How we can assess the gestational age of the fetus? So we can tell the gestational age of the baby based on the length. So if the baby's length is less than 25 centimeter, we can tell the age in months by giving the square root of crown heel length. By giving the square root of, let us keep the length of the baby is 25 centimeter. So the gestational age will be of square root of 25, which is 5 months. So what normal birth length is 50, right? Normal birth length is 50 centimeters. So if it is 50 centimeter, we have to use more than 25 centimeter. It is 50 by 5, which is almost 10 months. So this gives the gestational age of the baby again. So this rule is called as rule of Hasse. So this is rule of Hasse. And we have one more thing for the gestation age classification, that is Ballard score. So remember only this Ballard score will use neuromuscular maturity and physical maturity of the baby. So we have parameters of the neuromuscular maturity and we have parameters of the physical maturity by skin, hair, dust, ears, genitalia in male and female. So we'll include all these parameters and we can tell till 20 weeks. That is, the least score is -10, which corresponds to 20 weeks, and the maximum score is 50, which corresponds to 44 weeks. So remember only this: neuromuscular maturity, physical maturity, least score, and the maximum score of the Ballard scoring. Right. So next is the classification of babies based on the birth weight and gestational age. There is something called SGA, that is small for gestational age or small for date babies. These babies are called as microsomia. So this corresponds to less than 10th percentile or less than 3rd centile. Less than 10th percentile or less than 3rd centile or less than -2 standard deviation. So all these are individual charts. One is proportion chart, one is standard chart. So one is Z-score chart. So these charts gives the less than 10th percentile or less than 3rd centile or less than 2 standard deviation. So anything between 10 and 90 is normal. Anything between 10 and 90 is normal. Anything more than 90 is called as macrosomia. So you can answer this question. In asymmetrical IUGR, which organ is not affected? It is subcutaneous fat, muscle, liver, brain.
So subcutaneous fat.
No.
Muscle.
No. The answer here is brain. So we'll see. So this is an IUGR baby. So SGA is the statistical definition that we all know, that is less than 10th percentile. It is a statistical definition, whereas IUGR is the clinical definition. Clinical definition means this is the IUGR looking baby. IUGR looking baby will be having this loose skin folds, peeling of skin, a thin umbilical cord, a old man appearance. So this is something of a malnourished baby. This is a malnourished baby intrauterine. Intrauterine malnourishment is called IUGR. That is intrauterine growth retardation. Okay. So we have two things. We have two things, that is symmetrical IUGR and asymmetrical IUGR. Symmetrical IUGR is nothing but a hypoplastic baby. The overall the baby will be very small. Whereas in asymmetrical IUGR baby, it is a malnourished baby. We can tell it in some other terminology, means this hypoplasia is due to decrease in number of cells and decrease in size of cells. So in symmetrical IUGR, both number and size will be decreased, whereas in asymmetrical IUGR, the cell number will be normal, whereas the size of the cell will be decreased. Okay. So this symmetrical IUGR, if it is occurring, it occurs in the insult in the first trimester itself. So during the embryonic phase itself, the insult has to occur. It may be a radiation exposure or it may be a drug exposure in the first trimester. Whereas in asymmetrical IUGR, that insult occurs in the later life. So here in symmetrical IUGR, because of the embryo itself is affected, all organs are affected. Whereas the head circumference, chest circumference, abdominal circumference, that is the brain, lungs, heart, and all the abdominal organs, everything will be of small. Whereas in asymmetrical IUGR, the head circumference will be normal. The brain will be normal in asymmetrical IUGR. Okay. So these symmetrical IUGR will take a very long time to catch up the growth, whereas asymmetrical IUGR babies will catch up the growth early. So birth weight kammiya irundhuchu appadinalo, the symmetrical IUGR normal weight reach avradhukku romba naal agum, whereas asymmetrical IUGR will reach early. So now we can clear our question that in symmetrical IUGR, all organs are affected, whereas asymmetrical IUGR, our head circumference, that is brain, is bad. Okay. So IUGR la symmetrical, asymmetrical. So if everybody is comfortable with Tamil, okay. If somebody is having difficulty with Tamil, you can put a message. Okay. So symmetrical and asymmetrical difference kandupidikalana, we have a formula, that is Koncpt index. Koncpt index formula we have to remember, that is birth weight in gram divided by length in centimeter cube into 1000. Or 3 kilo baby na 3000 grams divided by 50 centimeter cube into 1000. That is normal. So if this value comes less than or equal to 2, it is symmetrical IUGR. If this comes more than or equal to 2, it is symmetrical IUGR. Less than 2, it is asymmetrical IUGR. So this Koncpt index formula we have to remember for IUGR. So there are few differences between IUGR and preterm. So IUGR babies will have hypoxia because of chronic stress. Preterm also will have hypoxia. So these are all common features. Hypoglycemia and hypocalcemia will be there in IUGR, and preterm also hypoglycemia and hypocalcemia will be there. So the major difference is here in IUGR, the respiratory distress, if the baby is having, it is because of meconium aspiration, whereas in preterm, the respiratory distress is because of HMD, that is hyaline membrane disease, and AOP is apnea of prematurity. Because of poor brain growth, poor lungs growth, they will be having respiratory distress. IUGR babies will have polycythemia, and preterm babies will have chances of getting anemia. And IUGR babies, there is very less chance of intracranial hemorrhage, whereas preterm babies, the chances of intracranial hemorrhage is more. So both will be a low birth weight or very low birth weight babies, but the problems what they are getting will be different. Okay. So next few things about infant feeding and breastfeeding. This again is there in the syllabus. A premature born baby at 33 weeks of gestation with a birth weight of 1500 grams. Which of the following you will choose or initial feeding method of choice? Intravenous fluids, IV fluids and oral feeding, orogastric tube, or any alternate route, total parenteral nutrition. Okay, we are getting late. So the answer here is orogastric tube. Someone texted. C. Yes, it is correct, Dr. Radhika. Yes. So the answer we have to know at what age of gestation, what feeding we have to give. Okay. So slide is done. So if the baby is less than 30 weeks or less than 1200 grams, the baby will not be having a proper sucking efforts or proper gut motility. So that time the ideal feeding method should be of IV fluids. We have to give nutrition to the baby via IV fluids only. So if the baby is 30 to 32 weeks or 1200 to 1500 grams, there will be a suckling burst will be there, but no coordination between suckling and swallowing. So till there is no coordination, we should not give a direct feeding, but the gut motility will be good. So we can give a NG feeding. This is nasogastric tube feeding we can give. In 32 to 34 weeks, there will be a mature sucking will be there and a slightly mature coordination will be there. But this sucking will not be enough. So we have to give the feeding in a pallata feeding. So the coordination between breathing and swallowing will be there in 32 to 34 weeks. So we can give a pallata feeding. Whereas after 34 weeks or after 1800 grams, the suckling will be very good. And the coordination between sucking and swallowing also will be good. So we can go for a direct feeding. So the preterm baby needs the important supplements. So these are all the common supplements we have to give because the stores will be very less in the preterm baby. Calcium we have to give 120 to 150 mg per kg per day. Phosphorus, remember half of this, that is 60 to 90 mg per kg per day. Vitamin D, normally how much we are giving the same dose, that is 400 international units per day. Iron will give 3 mg per kg per day. So this calcium and phosphorus for a preterm baby, we have to give till the baby reaches 38 weeks or the baby reaches 2 kg weight. This vitamin D and iron we have to give till 1 year of age. So the next thing is attachment. These questions also they may ask, that is the attachment, you can remember it as camel, C-A-M-L. So these 4 things is important. That is the chin should be touching the breast and this areola should be completely inside the baby's mouth and baby's mouth should be wide open and the lower lip should be averted. So remember these 4 things should be there for a proper correct latch on to the breast. Okay, so the next is contents of the breast milk compared with cow's milk. This again numbers, it will be easy to remember. So don't worry, the calories of the human milk and cow's milk is almost same. It is 65 kilocalories in human milk and 67 kilocalories in cow's milk. Remember it is same. So carbohydrate again, the more carbohydrate in human milk is lactose and the value is 7.4 grams. Whereas in cow's milk it is update reverse. It is 4.7 grams, which is less in cow's milk. And protein again 4.5. Sorry, protein is the whey protein is more in human milk, whereas casein is more in cow's milk. Overall, if you compare the protein content of the human milk is less compared to that of cow's milk, whereas the good protein whey is more in human milk than cow's milk. Fat again, the fat percentage is 4.5 grams in both human milk and cow's milk. The 4.5 is an important question. They may ask in other exams also. இது எப்படி சொல்றது 90s kidsக்குலாம் தெரியும். There is a favorite ad. இந்த அர்ஜுன் அம்மா யாரு is the நாலரை பால் ஆரோக்கியா. அவங்க இதை வச்சு தான் ஆட் போட்டாங்க. So fat content is equal to that of breast milk. That is 4.5. Okay. Sodium again, sodium is 6.5 in human milk, 25 milliequivalents in cow's milk. So those cow's milk fed babies, there is the chances of hypernatremic dehydration will be there in the bottle fed babies. So this is because of high concentration of sodium. Again, calcium and phosphorus. Overall, calcium and phosphorus is more in cow's milk, whereas the calcium to the phosphorus ratio is more in human milk. So the calcium and phosphorus should be in equal ratio. The ratio should be of more than 2 for the better absorption of the calcium and phosphorus. So it is good with breast milk compared to cow's milk. Iron, folic acid, vitamin C are all high in human milk, whereas vitamin A, B12 and all is high in cow's milk. So human milk also will be getting diseases like hemorrhagic disease of newborn because of no vitamin K in breast milk. Breast milk jaundice will get, touch infections will get, rickets will get, whereas in cow's milk we can get tetany, iron deficiency anemia and milk allergies. So all these things are common in cow's milk. So next is storage of breast milk. We can keep an expressed breast milk in room temperature for 8 hours, in a domestic fridge for 24 hours. We can keep the milk frozen at -20 degrees Celsius for 3 months. Okay, so this storage of breast milk duration again is important. 8 hours, 24 hours and 3 months. And So preterm, I want to tell one thing about preterm here. So what is the body temperature? To categorize the newborn is having cold stress. So we have options 36.5 to 37.5, which is normal temperature. 36 to 36.4 is cold stress. Cold stress, that is mild hypothermia. 32 to 36 is moderate hypothermia, whereas less than 32 is severe hypothermia. So the answer here is 36 to 36.4. So thermoregulation, so this we saw 36.5 to 37.5. Hypothermia is less than 36.5. Mild is 36.5 to 36. Moderate is 36 to 32. Severe is less than 32. Hyperthermia is more than 37.5. So these numbers we have to remember. And one thing is here to keep in mind is the newborns will neither shiver nor sweat. Hyperthermia achna verkadu, hypothermia achna shiver avadu. So then how they will produce heat? So what are the methods of heat production? Normally voluntary and involuntary methods. Voluntary will produce from the muscle activity. Involuntary is the major thing is shivering, whereas newborn will not shiver. So in non-shivering thermogenesis is the mechanism of heat production in the newborn babies. So this is mainly because of the brown fat. This brown fat is an adipose tissue which is usually present in the interscapular area, biceps, triceps, over the adrenal. So these are all the locations: biceps, triceps, interscapular area, and adrenal. So this brown fat is responsible for the non-shivering thermogenesis. And the methods of heat loss we have to remember. Methods of heat loss we have to remember. Four important mechanisms here is: one is radiation, second is convection, third is conduction, and fourth is evaporation. Radiation அப்படிங்கிறது வந்து room temperature. So if the room is cold, the heat will lose. That is radiation. Convection is source of cold air. So இப்போ ஒரு ஃபேன் ஓடுது இல்ல ஏசி ஓடுது, விண்டோ திறந்திருக்குது, அதனால ஹீட் லாஸ் ஆகுது அப்படின்னா that is convection. Conduction is by contact with the cold surface. When we are receiving a baby in a cold towel, the baby will lose heat. Okay, that is contact. Or cold surface la padukka vechom appadina heat loss. That is conduction. Evaporation is because of the baby is wet. When we are drying the baby, the heat loss will be there. So in this we can prevent radiation heat loss, convection heat loss, conduction heat loss, whereas evaporation heat loss is inevitable. We can't prevent evaporation heat loss because we have to dry the baby. Okay. So a normal neonate, this I have given in the material, the normal birth weight, birth length, head circumference, all those numbers. It is easy to remember. You can go through that table. And one reflex I want to tell is Morose reflex. That is the reflex center for Morose reflex is stretch receptors of neck. Stretch receptors of neck. Testing question we all know. We'll keep in supine position. We'll lift to 30 degrees. We'll gently drop the head of the baby. That is the procedure. So the time of appearance of reflex is 28 weeks of intrauterine life. And response observed, we'll see the time of disappearance is before 7 months. It should disappear before 7 months. Okay. So these are all the components of Morose reflex. That is 7 components. So starting from shoulder, abduction of shoulder, extension at the elbow, opening of hands, followed by closing, reverse, closing of hands, flexion at the elbow, abduction of shoulder, and last the baby will cry. So these are all the 7 components of Morose reflex, and Morose reflex should disappear before 7 months. So remember, it will appear at 7 months of intrauterine life. It has 7 components, and it will disappear before 7 months of after birth. So remember 7 for Morose reflex. Okay. So complete Morose reflex na all 7 components will be there. Incomplete Morose reflex will be there in premature baby. Premature baby la verum abduction extension da varum, opening of hands, closing, reverse alla varadu. So less prominent or absent reflex is will be seen in the severe asphyxia, meningitis, hypothermia, kernicterus. So all these things will be having less prominent reflex. Asymmetrical, one side normal reflex, one side abnormal reflex. This will be there in injuries, palsy, fracture, All those things will be having. Exaggerated reflex will be there in HIE, hypoxic ischemic encephalopathy. Sorry. Okay. So we all know the newborns will lose weight at birth. The term babies will lose 8 to 10% after birth. Preterm babies will lose 10 to 15% after birth, whereas the IUGR babies will never lose weight after birth. Okay. It will start gain weight from the day 1 of birth. So the term babies will regain birth weight at 1 week. Preterm babies will regain the birth weight at 2 weeks. Preterm catch-up growth, again the head circumference will catch up to normal at 1.5 years, weight at 2 years, and height at 4 years. So these things we have to remember. And okay, so few diseases of newborn we have to see. So one is RDS, that we all know, HMD, hyaline membrane disease. It is because of surfactant deficiency. The surfactant is secreted by type 2 nematocytes. From 20 weeks of intrauterine life. So 20 weeks la surfactant produce it will peak by 28 weeks to 34 weeks. 34 weeks maximum production will be there in 28 to 34 weeks. So RDS surfactant deficiency because of prematurity. Premature babies la nematocytes mature lung maturity meconium aspiration, again this meconium will go and injure the alveolar nematocytes, which will cause surfactant deficiency. Diabetic babies, remember this diabetic babies also can cause RDS. So RDS is not just present only in preterm babies. It can be due to meconium, it can be due to infant of diabetic mother, because insulin will block the maturation of nematocytes. Okay, and asphyxia, again hypoxic injury to the nematocytes will cause less surfactant production. So these are all the risk factors. Male C-section or PPROM, second born twin are all risk factors for surfactant deficiency. These baby will have respiratory distress at birth. That is tachypnea, nasal flaring, grunting, intercostal retraction, subcostal retraction, cyanosis. The features of respiratory distress will be there within 6 hours of birth. So this is again important. Within 6 hours of birth, these babies will present with respiratory distress. So we have 2 severity assessment scores for RDS. One is Downey score. Just remember the names. One is Downey score, and second is Silverman Anderson score. So these are all the scores for the assessment of HMD, hyaline membrane disease. So if the total score is 10. If the score is 0 to 3, it is mild RDS. If it is 4 to 7, moderate RDS. If it is 8 to 10, it is severe RDS. So only remember the names, that is enough. I don't think so they will ask all these features. So names again important. So X-ray, the typical X-ray feature in the hyaline membrane disease is whiteout lung. This is a complete whiteout lung in the case of hyaline membrane disease. So management in 2 things. One is prevention and the second is the treatment. Prevention, we have to give antenatal corticosteroids. Anticipated mother, if it is less than 34 weeks, we have to give steroids. Steroid we can give dexamethasone and betamethasone. This we all will be knowing. Dexamethasone of 6 mg, 4 doses, 12 hours apart. Betamethasone is 12 mg, 2 doses, 24 hours apart. Okay. So other advantages of giving a steroid is it will prevent intraventricular hemorrhage, NEC, retinopathy of prematurity. All these things also it will prevent. And treatment, we have to start continuous positive airway pressure, CPAP, to keep the alveoli open. We have to keep the alveoli open, start CPAP as early as possible. And we have to give an artificial surfactant. Prophylactic surfactant is within half an hour of birth. We have to give surfactant even if there is no respiratory distress. For preterm baby distress illama surfactant kudukuradha prophylactic surfactant. Early surfactant abdina respiratory distress within 2 hours kulla kudukuradhu early rescue. After 2 hours kapram kudukuradhu later rescue. It is very simple to remember, right? So these are all the constituents of surfactant. Again, DPPA, dipalmityl phosphatidyl choline. It is also called as lecithin. And remember it is DPPC, dipalmityl phosphatidyl choline. And phosphatidylglycerol proteins, surfactant proteins, we have A, B, C, D type of surfactant proteins and cholesterol. Okay. So this surfactant protein deficiency, oversecretion will cause a disease called pulmonary alveolar proteinosis. So the second disease what we have to see is TTN, that is transient tachypnea of newborn. It is due to decreased clearance of the lung fluid after birth. So it will limit self-limit on its own. Usually the baby will present with tachypnea retractions at birth. This is the most common cause of respiratory distress in the term babies, whereas the most common cause of respiratory distress in preterm babies is RDS, what we saw. This is in term babies. Okay. So here the typical X-ray pattern is sunburst pattern. Because of prominent perihilar streaking here, can we see? These streakings will cause a sunburst appearance in the perihilar region because of engorgement of periarterial lymphatics with the fluid. So this sunburst pattern is typical of transient tachypnea of newborn. Usually it will resolve on its own. We have to give a supplemental oxygen and it will present with a hyperinflated chest. Can we see this increased intercostal space? This is because of hyperinflated chest. So management, again, only supplemental oxygen is enough. It will improve on its own. The third important respiratory disease is that is meconium aspiration syndrome. This meconium is nothing but a sterile, thick, black, green, odorless material in the intestine of the baby. Usually it will present at 14 to 16 weeks of gestation. The major content here is water. Okay. So this meconium aspiration again is the most common cause of respiratory distress in post-term babies and IUGR babies. So now we know preterm, the most common cause is RDS. In term, it is TTN. In post-term, it is respiratory. So post-term, it is meconium aspiration syndrome. Okay. So what are the complications of meconium? We should be knowing. So once the baby passes meconium, it will be a meconium stained amniotic fluid, MSAF. This meconium will get aspirated inside the trachea. So trachea ulla pochu appadina enna agum, airway obstruction agum with the meconium. So this airway obstruction can be a central airway obstruction or it can be a peripheral airway obstruction. Central airway na large airway, trachea, bronchi, idella obstruct ayiruchu appadina complete the baby will not breathe. So it will go for hypoxemia, hypercapnia, acidosis, all these things will be there. If it is bronchial level, peripheral airway obstruction, it can be complete block or partial block. Complete block, there will be complete atelectasis of that alveoli. The alveoli will go for atelectasis. Partial, it will be a ball valve mechanism. One side kaathu povum, inno side varadu. So only it will pump. The alveoli will bulge and burst. That will go for pneumothorax. Okay. So this meconium again will cause, it is a chemical, it will cause chemical pneumonitis. And the chronic fetal compromise because of this meconium can go for pulmonary vascular remodeling and go for primary pulmonary hypertension. So atelectasis, pneumothorax, hypoxemia, hypercapnia, acidosis, and PPHN are all the complications of meconium aspiration syndrome. Okay. So again, meconium aspiration classification, mild na, it requires 40% of oxygen for less than 48 hours. Moderate na, more than 40% of oxygen for more than 48 hours. Severe mass requires assisted ventilation. It can be CPAP or intubation and ventilation for more than 48 hours. So usually this will present with respiratory distress in 1 to 2 hours of birth. Now common presentation is 1 to 2 hours of birth. Okay, so here X-ray, there is no typical finding. Usually it will have the features of chemical pneumonitis will be there. Streaky patch density will be there. So treatment again, we have to give high frequency oscillatory ventilation. Surfactant is of no use here. We can use the inhaled nitric oxide for the primary pulmonary hypertension. So these are all few scenarios we can answer if you want to try. So scaphoid abdomen, shift of apical impulse, gurgling sound on the chest auscultation. Diagnosis. Scaphoid abdomen, shift of apical impulse, gurgling sound on chest.
The bottle எடுக்கோங்க கீழ போ.
Yes, it is CDH. CDH is correct answer. It is diaphragmatic hernia. The shift of apex to the contralateral side with absent breath sounds. It is pneumothorax. Persistent frothing at the mouth. persistent frothing in the newborn baby. It is tracheoesophageal fistula because of the blunt end of the esophagus. Tachycardia, cyanosis, shock, murmur, hepatomegaly. It is so obvious. It is cyanotic congenital heart disease. Cyanosis on a quiet baby which disappears on crying. Yeah, you can write this. Cyanosis on a quiet baby which disappears on crying. Anybody? This is quinal atresia. Okay. No, it's not top. Quinal atresia. Okay. Quinal atresia is the correct answer. So bloodstained froth from larynx is this we all know. Pulmonary hemorrhage. Sorry, it's not coming. It's pulmonary hemorrhage. So the last disease we'll see is the abnormality in the Crigler-Najjar syndrome. Uptake of bilirubin, defective hepatic conjugation, canalicular release, or reduced bilirubin bile excretion. Crigler-Najjar syndrome. We got answer B. Yes. The answer is correct. So we should be knowing a little bit about this neonatal jaundice because they are very fond of this topic. I don't know why they will ask. It is important. So normally 60% of the term babies and 80% of the preterm babies will have jaundice. It is normal. Okay. And this jaundice bilirubin level is more in babies compared to adult. Why? Because of turnover of hemoglobin, because of the lifespan of RBC in adult is 120 days. We all know in babies it is 80 to 90 days, whereas in preterm it will be 50 to 80 days. Whereas in preterm babies it is 50 to 80 days. So preterm will have still more chance of getting more of jaundice. Okay. So this I have given as a difference in common questions in that material. So physiological jaundice versus pathological jaundice. Physiological jaundice now jaundice after 24 hours of birth is physiological. Any jaundice within 24 hours of birth is pathological. Okay. So this physiological jaundice usually reaches maximum on 5th day in term babies and 7th day in preterm babies, and it will disappear on its own in 14 days. So remember, 1 week la the jaundice peak agum, 2 weeks la adve thana maranjirum. So that is physiological jaundice. Whereas pathological jaundice அப்படிங்கிறது it will persist even after 2 weeks in a term baby and 3 weeks in a preterm baby. That is pathological jaundice. Okay. So physiological jaundice or serum level will never cross more than 15. 15 oda kila dhaan irukum. It is less than 15 mg per deciliter always. Whereas the pathological jaundice serum level will be of more than 15 mg per deciliter, or this is per day levels. That is more than 5 mg per deciliter per day or 0.2 mg per deciliter per hour also we will read. Okay. And direct bilirubin, these values are of indirect bilirubin, whereas direct bilirubin of more than 2 is pathologic. And remember, these pathological jaundice babies will always have clay colored stools with yellow color urine. That is high colored urine with a clay color stool is pathological jaundice. Physiological jaundice, no treatment, disappear on its own. Pathological jaundice, always require treatment. So very basic bilirubin synthesis we have to know. It will take just 2 minutes so that we can remember the one-liners easily. Okay. So RBC lerundu hemoglobin varum. Hemoglobin contains 4 molecules of heme and 2 globin chains. These are all your biochemistry, you all will be knowing. And 1 gram of hemoglobin will give 35 milligram of bilirubin on turnover. So 1 gram of hemoglobin on destruction gives 35 milligram of bilirubin. Okay. So once the RBC lifespan is completed, it will divide it into heme and globin. This globin will go into amino acid pool, whereas this heme is converted into biliverdin by heme oxygenase. We all know here a molecule of carbon monoxide will be released. So this biliverdin is converted into bilirubin. This is unconjugated bilirubin, yellow color. Unconjugated bilirubin by biliverdin reductase. This we all know. So this bilirubin is taken to the liver by albumin. It has to bind with albumin to taken to the liver. So liver in liver we have a receptor, that is YZ ligand receptor. So this YZ ligand receptor will be there in the surface of the liver, So through this unconjugated bilirubin will enter inside the liver. That is ligand protein mediated uptake. It will enter inside the liver. So liver will make like this. Okay. So inside liver, it will get attached to the substrate, that is UDP, uridyl diphosphate is a substrate. It will get conjugated with the substrate and form UDP monoglucuronate. That is UDP monoglucuronate is the by the enzyme UDP-GT, UDP glucuronyl transferase. So remember these enzyme names again, it is important. This UDP monoglucuronate is the conjugated bilirubin, what we know. So this conjugated bilirubin will go into intestine via bile duct. So after reaching the intestine, this will get converted into stercobilin and urobilin for excretion by the normal gut bacteria. This is normal gut bacteria. And we have an enzyme called beta glucuronidase in our gut, which converts this conjugated bilirubin, into unconjugated bilirubin. That is deconjugation process occurs by the enzyme beta glucuronidase. So this deconjugated bilirubin will go via enterohepatic circulation to the unconjugated bilirubin pool in the blood. So this is very basic bilirubin metabolism we should know. So now we can tell the diseases very easily. Okay. So here again, this bacteria will inhibit this enzyme to prevent the enterohepatic circulation. This bacteria will inhibit this enzyme to prevent this deconjugation. So what are the causes of physiological jaundice? One is increased bilirubin load. Two is defective uptake from the plasma. Third is defective conjugation. Fourth is decreased excretion. Fifth is increased enterohepatic circulation. So this we saw. The first is increased production. Second is defective uptake. Third is
post-streptococcal answers. Most common type of nephritic syndrome in children is post-infectious glomerulonephritis.
Somebody speaking. Can you please mute? Hello?
Hello,
can you please mute? Hello? Okay, the third cause is decreased defective conjugation, and the fourth is deconjugation, excretion, and the fifth is the enterohepatic circulation. We all know. Okay, so here, if there is a defective conjugation because of UDP glucuronil transferase deficiency, it is Crigler-Najjar syndrome. Defective ligand protein mediated uptake is Gilbert syndrome. If there is increased hemolysis because of RH incompatibility or ABO incompatibility, we'll be having hyperbilirubinemia. And remember this thing: if the baby is not taking feeding properly, it is because of poor feeding. Because of poor feeding, dehydration, and delayed passage of meconium, there will be increased enterohepatic circulation. So this increased enterohepatic circulation is due to breastfeeding jaundice. So this is called as breastfeeding jaundice. Whereas we have one more entity called as milk jaundice. So this breast milk jaundice.
Very good. Acute proliferative glomerulonephritis. என்னது சொல்றாங்க? Post-streptococcal glomerulonephritis, acute proliferative post-streptococcal, இது எல்லாமே cola-colored urine, subepithelial deposits. அப்புறம் not done. அப்பனா anti-endothelial antibody, ANCA, அப்புறம் immunofluorescence showing deposits of IG and இது எல்லாமே இருக்கு. Subepithelial hump இருக்கு. Okay. அடுத்து IgA னா கண்டிப்பா IgA deposition இருக்கும். Similar to அதெல்லாம் கூட ஓரளவு in case நான் எழுதிடுறேன். அடுத்து IgA nephropathy. அப்பனா என்னது? True regarding IgA nephropathy na.
Excuse me. Hello. I think she's not hearing. Okay. So breast milk contains these four things we have to remember. That is antibodies in the breast milk, beta glucuronidase of breast milk, 3-alpha-20 antibodies will go and inhibit this gut bacteria. This beta glucuronidase will go and act for deconjugation, and this 3-alpha-20 beta pregnenolone is an important question. They will ask 3 alpha 20 beta pregnanediol is a component in the breast milk will go and inhibit this UDP glucuronide transferase, our star enzyme. So once this enzyme is inhibited, there will be conjugated hyperbilirubinemia, unconjugated hyperbilirubinemia, and more lipase activity will cause increased free fatty acids. These free fatty acids will go and block this YZ ligand. So this causes the breast milk jaundice. Okay, so the difference between breastfeeding jaundice and breast milk jaundice, breastfeeding jaundice normal second day or third day vandrum. Whereas breast milk jaundice, milk we have to feed for at least for a week. So 1 week, 1 to 2 weeks, breast milk jaundice. This is because of poor breastfeeding, whereas this is because of breast milk. Normal breast milk components jaundice. We know the components, that is antibodies, increased lipase activity, and third is 3 alpha 20 beta pregnanediol. So this is an important question here. So the treatment for breastfeeding jaundice is we have to increase feeding, and treatment for breast milk jaundice, don't stop breast milk. Do not stop the breast milk. We have to continue the breastfeeding. It will settle on its own. So this is breast milk jaundice. And a few difference about this Crigler-Najjar and Gilbert I want to tell. Crigler-Najjar is type 1 is autosomal recessive inheritance, type 2 is autosomal dominant recessive inheritance, and Gilbert is both autosomal dominant and recessive.
2 days diarrhea. இதெல்லாம் வந்து என்னது normal C3 level. அப்பனா Burger disease. Post-streptococcal in children. Subepithelial deposit. Cola colored urine. Enna colored urine? Very good. Cola colored urine.
Okay. She stopped. So this is complete absence of glucuronide transferase enzyme, whereas in type 2 there is a partial absence of the enzyme, whereas in Gilbert the partial absence of the enzyme, and the major thing is defective bilirubin uptake we read. Okay, so complete absence of enzyme, there will be severe unconjugated hyperbilirubinemia.
ACE inhibitors can be used, can present as persistent microscopic hematuria, IgA deposition in the mesangium. இது வந்து increased. Okay, அதான் வந்து என்னது IgA nephropathy, IgA nephropathy. அடுத்து வந்து என்னது okay.
Okay, so Crigler-Najjar type 2. Crigler-Najjar type 2 has mild hyperbilirubinemia of usually less than 10, whereas Gilbert syndrome will have still more. Gilbert syndrome will have still more less bilirubin, because of defective uptake. Okay, so the chances of getting kernicterus is more in Crigler-Najjar type 1, less in Crigler-Najjar type 2, and there is no kernicterus in Gilbert syndrome. So all these can be asked as a question. And the treatment for type 1 is phototherapy, and we have to go for liver transplantation. The treatment for type 2 is we can give phenobarbital because the enzyme is only partially absent. We can activate the enzyme by giving enzyme inducer phenobarbital. Gilbert again we can give phenobarbital. Okay, so this finishes the Crigler-Najjar and Gilbert syndrome. Kramer's rule we all will be knowing. Phase, it is less than 5 is phase. Remember it as less than 5 phase. 5 to 10 in chest and abdomen, and 10 to 15 in lower abdomen and thighs, 15 to 20 in arms and lower legs. If it is more than 20, palms and soles, it will be more than 20. So this is Kramer's rule we all will be doing. So complication of jaundice we all know, that is once if this bilirubin is increased, it will cross the blood-brain barrier, it will reach the brain and causes kernicterus. Okay, so where this bilirubin will go and deposit in brain? Usually it will, in preterm babies, it will deposit in thalamus, subthalamus, and nuclei of cranial nerve. In term babies, again subthalamus, lobus pallidus, hippocampus, auditory nuclei, dentate nuclei. So all these are parts of basal ganglia. All these are parts of major part of basal ganglia. The question here is the cortex of the brain is bad. The bilirubin will never go and deposit in the cortex of the brain. Okay. So we can get acute bilirubin encephalopathy. That is acute blindness, bilirubin induced neurological damage. Bilirubin induced neurological damage. We can get a chronic permanent bind. That is Koncpt. We can get cerebral palsy because of Koncpt. The type of cerebral palsy in Koncpt they may ask, that is dystonic or dyskinetic type of cerebral palsy or chorioathetoid type of cerebral palsy. The child will be having a chorioathetoid movements. So it is chorioathetoid type of cerebral palsy. So this finishes jaundice. Jaundice treatment we all know, we'll give phototherapy. The numbers they may ask. Phototherapy is a blue light emits 400 to 520 nanometer. Bilirubin absorbs 425 to 475 nanometer. Adoda flux irradiance எவ்வளவு இருக்கணும் அப்படினா 15 microwatt per centimeter square per nanometer. Okay. So we have to keep at least 45 centimeters near to the baby. The light should be of 45 centimeters near to the baby. Mechanism we all will be knowing. Photo-oxidation, configurational photo-isomerization and structural photo-isomerization. The மூணு mechanism இருக்கு. மூணுல the major mechanism is structural photo-isomerization. The bilirubin will get converted into lumirubin, and this lumirubin is water soluble. Okay, so this finishes. This lumirubin will get excreted in the urine easily. So this finishes jaundice. So now we can answer. All are true about breast milk jaundice except there is unconjugated hyperbilirubinemia. Yes. Some babies need treatment with phototherapy. Yes. Breastfeeding is contraindicated. Remember, the breastfeeding is never contraindicated in breast milk jaundice or breastfeeding jaundice. So the answer is breastfeeding is contraindicated. Okay. And
can you please explain breast milk jaundice, sir?
Breast milk jaundice, sir.
Yes, sir. Yes, sir.
Okay. Okay.
So just
so
explain overall, sir.
Okay. Breast milk contains few components that will cause jaundice. So what are the components in the breast milk is we have antibodies.
Okay, sir.
And we have this 3-alpha-20-beta-pregnenolone. So remember at least only this 3-alpha-20-beta-pregnenolone, because this will go and inhibit our UDP-GT enzyme, which is the major enzyme for the conjugation of the bilirubin. So that is inhibited because of breast milk. We are getting the jaundice. That is breast milk jaundice. Okay. Breastfeeding jaundice is because of poor feeding. We are getting jaundice. That is breastfeeding jaundice.
Okay, sir. Okay, sir. Thank you, sir.
Okay. Okay. So Koncpt, the staining of brain is more intense in the spinal cord, corpus callosum, basal ganglia, cerebral cortex. So we all know the answer is basal ganglia. So this is the last disease. We'll see the infant of diabetic mother manifest. What are all the symptoms? What are all the things it will manifest? Hyperglycemia, hypoglycemia, hypocalcemia, fetal defects, hyperbilirubinemia. The answer is Yellame, except hyperglycemia. The baby will have all the features here. Okay. So infant of diabetic mother pathogenesis is very important. We all know it is infant of diabetic mother. Mother is sugar adhigama irukku. So and she is not having insulin. So what mother will do? She will give all the sugar to the baby via umbilical cord. So baby will receive more sugar and the baby's pancreas is fine. So the baby's pancreas will start secrete more of insulin. So baby ta nariya sugar irukku, nariya insulin irukku intrauterine. And insulin is an anabolic hormone. So it will cause the baby to overgrow actually. It will make a macrosomia because of insulin. Hyperinsulinemia will cause macrosomic baby. So it will be a big baby. Infant of diabetic mothers will be large. And intrauterine there is of no issues. And once the baby is coming out, we will cut the umbilical cord. So suddenly the heavy sugar inside the baby is dropped, but the baby is having more insulin. So what will happen? Sudden hypoglycemia at birth. So this is a very basic pathogenesis of IDM. Let us see one by one. So infant of diabetic mother la idha questions. Congenital malformation la most common is cardiovascular malformation. CVS, CNS, GIT la most common is cardiovascular malformation. CVS la most common malformation is VS. Sorry, CVS la most common malformation is VS. Okay, whereas most specific for infant of diabetic mother is EGA. It is transposition of great arteries followed by asymmetrical septal hypertrophy. ASH. So this is more specific for infant of diabetic mothers, whereas most common is VSC. The most common in the most specific இதெல்லாம் போட்டு திருப்பி கேட்பானுங்க. So you have to remember these things. Okay. So CNS la most common congenital malformation is spina bifida. Spina bifida. Spina bifida la occulta followed by aperta. Occulta na it won't be visible. Aperta na it will be visible. Okay. Whereas most specific malformation is caudal regression syndrome. அதாவது ஸ்பைனுக்கு கீழ ஒண்ணுமே இருக்காது. The caudal part will not be developed. That is caudal regression syndrome. The most common GI malformation is atresia. Atresia of duodenum, jejunum, ileum. The atresia is more common in GAT, whereas most specific is hypoplastic left colon. Hypoplastic left colon. So this we have to remember in IDM. So this is the congenital malformation. So we have finished the congenital malformation. Macrosomia na solita because of increased insulin, anabolic hormone, there will be increased fat deposition mainly in the shoulder region, interscapular region. In the இடத்துல தான் வந்து fat deposit ஆகும். ஓகேவா? So interscapular region, shoulder region எல்லாம் deposit ஆகிறதுனால there is a chance of getting shoulder dystocia. Shoulder dystocia is more common in IDM. அதனால Erb's palsy வரும். The birth injury most common is Erb's palsy because of shoulder dystocia. Again, hypoglycemia I told. Hypocalcemia, hypomagnesemia is also there in infant of diabetic mother because of hypocalcemia. Insulin will cause parathormone, decreased activity of the parathormone. Hypomagnesemia, diabetic mothers will lose more of magnesium in urine. Mother oda magnesium alla mother urine le poirum. So no magnesium will come to the baby. So adanal baby will be hypomagnesemic. Okay. Hyperbilirubinemia, again insulin nala. Insulin will inhibit our UDP-GT. UDP glucuronil transferase enzyme. Adanal we'll get jaundice. Respiratory distress also I have already told. RDS because of IDM. Cardiomyopathy because of dilated cardiomyopathy because of big heart. So this finishes infant of diabetic mother. Treatment of hypoglycemia kepanga. Hypoglycemia is less than 45 mg per deciliter is hypoglycemia. So hypoglycemia, if it is less than 20, if it is more than 20. Less than 20, more than 20 on this symptomatic baby or asymptomatic baby. Symptomatic baby na or sugar vandu 25 da irukku, more than 20, but the baby is having convulsion, fitted the hypoglycemic convulsions. Asymptomatic na sugar 25 da irukku, but there is no convulsion. Okay, so asymptomatic baby ki we can give a measured palada feeding. On the weight ki evlo feeding kudukunumo ada measure panni we will give a measured feed. Whereas for symptomatic baby or if the sugar is less than 20, we have to give IV 10% dextrose 2 ml per kg. IV 10% dextrose 2 ml per kg. Okay, so after that we have to check the sugar after 1 hour. So IV kudutalo illa feeding kudutalo after 1 hour we have to check the sugar. So this is the management of hypoglycemia. Hyperglycemia is blood sugar of more than 125 mg per deciliter. I read in one paper the serum blood glucose that is more than 145 mg per deciliter. So this is blood glucose, this is serum glucose. Okay, so read the question properly. And the most common cause of hyperglycemia is sepsis. So we finished newborn. This is the last question. At birth, the infant born to a diabetic mother was lethargic. Few minutes after birth, his blood glucose was 13 milligram percentage. What should be the next? So less than 20, we have to give IV dextrose. Okay, so this finishes newborn. So the second topic what we are going to see is growth and development. Okay, So growth na is a terminology of increase in size and length. Development is maturation of skills. Because of the growth, what skills the baby is acquiring. Weight அதிகமாகுது, height அதிகமாகுதுங்கிறது growth. நிக்கிது நடக்குது அப்படிங்கிறதெல்லாம் development. So this we know the basic, right? So there are 4 golden laws of growth. One is the growth is a continuous and orderly process. Okay. It is a continuous and orderly process, but it stops when the maturity is attained. Maximum reach ஆனதுக்கு அப்புறம் it will stop. The second is the growth is always in the cephalocaudal direction. Head to toe direction la da irukum, and always it is centered to the periphery, proximal to distal, and it is a sigma shaped curve. So what is the shape of the growth curve? They will ask. It is a sigma shaped curve. It has 2 peaks. That depicts the sigma shape. Okay, so it is cephalocaudal, proximal to distal, sigma shape. So these 4 are the golden laws of growth. So different tissues of the body growth we'll see. Somatic growth or graph is a sigma shape curve, we know. So it has 2 peaks. One at one at birth almost 3-4 years it will be very fast. So then from 4 years till 12 years it is static. Okay. So this it is static from 4 years to 12 years. So 12 years there is a pubertal spurt. Adanala again it will grow fast. So this is the sigma shaped curve. So somatic growth is a sigma shaped curve. We have to remember. Second is brain growth. Brain growth till 2 years it will reach. 5 years will reach the adult brain growth. Followed by lymphoid growth. Excuse me. Lymphoid growth is maximum in the mid childhood. Almost for 7 to 12 years it will be peaking. After that it will decrease. Followed by gonadal growth. Gonadal growth till 10 years onnu irukadu. So after puberty there will be a spurt in the gonadal growth. So these are all the different patterns of growth we have to remember. The hormones responsible for growth. Common the knowledge hormone we should know. Growth hormone is responsible for somatic growth. Insulin is responsible for fetal growth. So we know intrauterine growth growth hormone கிடையாது. It is insulin like growth factor இதெல்லாம் தான் responsible. Thyroxine is responsible for brain. Thyroxine is hypothyroidism will have mental retardation, right? Thyroxine is responsible for brain growth and skeletal growth. Whereas sex hormones we know gonadal growth. So these are 4 common hormones we should remember. So how we are going to assess the physical growth? How we are assess the growth? Physical growth, tissue growth, bone growth, and dental growth we should be knowing. We'll start from the simple one. Tissue growth la common கேக்குற question. Tissue growth அப்படிங்கிறது skin fold thickness. Skin fold thickness measure பண்றதுதான் tissue growth. That is subcutaneous fat measure பண்றது. The instrument what we use is Koncpt caliper. இதெல்லாம் பேர் கேட்பாங்க. Koncpt caliper we'll use to measure the skin fold thickness. Okay. So usually we'll measure this in biceps, triceps, again interscapular region, and superior iliac region. We'll measure this tissue growth. Okay. Anybody wants to try this question? Total number of teeth in the 8-year-old child.
24.
Yes, it is correct. 24. Oh, no. Very good. Okay. So next we'll see the dental growth. So dental growth we know primary teeth, milk teeth, deciduous teeth or teeth. Permanent teeth is a random set of teeth. So primary teeth mottham 20 teeth. Okay. Permanent teeth is 32 teeth. We all know. So the first teeth to erupt in primary teeth. Remember this mnemonic IMC. That is incisor, molar, canine. Incisor 6 months, molar 12 months, canine 18 months. So these are the order of eruption of the teeth. Incisor lower central incisor is the first teeth to erupt. Okay. So primary teeth 20 teeth. Permanent teeth 32 teeth. இதுக்கு MIP. Remember molar, incisor, premolar. So this is years. 6 years, 7 years, and 8 years. If a person is having a third molar, he is above 18 years of age. So only this much you remember in the dental growth, that is enough. And regarding the question, remember the total number of teeth in 6 to 11 years of age is a constant number 24. Okay, it's 24, but it will be a mixed teeth. This 24 contains both primary and permanent teeth. So how to differentiate? Number of permanent teeth is age minus 5 into 4. For 10 வயசு பையனுக்கு எவ்வளவு இருக்கும்? 20 permanent teeth இருக்கும். So 20 teeth are permanent, remaining 4 teeth are temporary. Okay. So this formula is very simple to remember. Okay. So the next thing is physical growth. Weight again, weight will measure using a weighing scale, electronic weighing scale. அதெல்லாம் நமக்கு தெரியும். So birth weight, the weight progression I had given in the chart. So remember only common questions. The birth weight doubles by 6 months, triples by 1 year, quadruples by 2 years. Okay. So this we have to remember in weight. Length, height la enna question கேட்பாங்கன்னா length is a supine height. படுக்க வச்சு பார்க்கிறது length, நிக்க வச்சு பார்க்கிறது height. So till 2 years it is very difficult to measure the height. Baby நிக்க வச்சா நிக்காது. So till 2 years we will measure length. So this will measure using infantometer. Infant na 1 year வரைக்கும் தான், but infantometer will use till 2 years. Okay. So this we have to remember. Height will measure using stadiometer. ஓகேவா? சோ இந்த பேர் ஞாபகம் வச்சுக்கோங்க. பர்த் லென்த் இஸ் 50 சென்டிமீட்டர். இது வந்து டபுள்ஸ் பை 4 இயர்ஸ். டபுள்ஸ்னா 100 சென்டிமீட்டர் அட் 4 இயர்ஸ். ட்ரிபிள்ஸ் பை 150 சென்டிமீட்டர் பை 12 இயர்ஸ். ஓகே. சோ வெயிட்ல இதான் கொஸ்டின், லென்த் ஹைட்ல இவ்வளவுதான் கொஸ்டின். மிட் டேர்ம் சர்க்கம்ஃபரன்ஸ் we all know. மிட் டேர்ம் சர்க்கம்ஃபரன்ஸ் is an age independent criteria. இது age independent criteria. Again 6 months ல இருந்து 5 years வரைக்கும் it is a constant value of more than 13 க்கு மேல தான் இருக்கணும். The tape what we use to measure, நார்மலா மெஷரிங் டேப்ல மெஷர் பண்ணா போதும், but we have a special tape called Shakir's tape. Shakir's tape. இந்த Shakir's tapeல there will be colors red, yellow, green இருக்கும். The baby falls in green zone, it is normal. Yellow is moderate malnutrition. Red is severe malnutrition. Okay. So that finishes mid-arm circumference, and last is head circumference. Okay. So head circumference, normal head circumference is 33 centimeters. 2 years la வந்து 95% of the head circumference reach ஆயிரும். 5 years la 99% of the head circumference reach ஆயிரும். So only this much if you remember, that is enough. Okay. Is same things only. And the common formula to calculate the expected weight, height, head circumference, all these formulas for last minute revision, we have to remember this. I had given this in material also, you can go through in that. Okay. And this indexes also. These are all the age independent anthropometric criteria. Okay. The important question again, it is specifically mentioned in the syllabus, growth chart. So we can expect question from this growth chart. We all know growth chartல ரெண்டு axis இருக்கும், ஒரு x axis ஒரு y axis. X axis will keep age, y axis will keep the parameter what we are checking. It can be weight, it can be height, it can be head circumference, it can be it cannot be mid-arm circumference, because mid-arm circumference is a age independent criteria. BMI, it can be growth velocity, anything we can keep. Okay. So this let us understand this chart easily. So we have two types of chart. One is standard chart and second is proportion chart. Standard chart la enna irukum appadina percentile lines irukum. Whereas proportion chart la enna irukum appadina standard deviation line, adhaadu z scores irukum, standard deviation irukum. Percentile chart la we have percentile from 3rd percentile to 97th percentile. 3rd, 15th, 50th, 85th, 97th percentile varaikku irukum. Z scores வந்து -3 standard deviation ல இருந்து +3 standard deviation வரைக்கும் இருக்கும். ஓகேவா? So anything less than 3rd percentile or anything above 97th percentile is abnormal, or anything below -2 standard deviation, anything above +2 standard deviation is abnormal. So this is the basic difference. நிறைய பேருக்கு புரியாது. It is difficult. I agree. So let us simplify this with the graph. Okay. So இது வந்து 50th percentile. Sorry, we'll take with the standard chart, that is 0 standard deviation. So 0 standard deviation க்கு மேல 1 standard deviation, 2 standard deviation, 3 standard deviation. கீழ வருது -1 standard deviation, -2 standard deviation, -3 standard deviation. Okay. So this is standard deviation chart. So anything coming between 2 standard deviation ல இருந்து -2 standard deviation to +2 standard deviation குள்ள இதுக்குள்ள ஃபாலோ ஆவற எல்லாமே வந்து நார்மல். ஓகே. So if 0 இங்க வந்து let us keep 1 year. So 1 yearல the weight of the child இங்க 3 கிலோ இருக்குன்னா 3 times ஆகணும் 9 kg ன்னு வெச்சுக்கோமே. So 9 kg at 1 year இங்க வருது. So if it comes here somewhere here it is normal. So this is standard deviation chart. Proportion chart இதே தான். So zero standard deviation percentile chart. Zero standard deviation correspond to 50th percentile. 1 standard deviation correspond to 85th percentile. 2 standard deviation correspond to 97th percentile. -1 15 -2 3rd percentile. So இதுதான் percentile chart. ஓகேவா? So percentile chartல 2 standard deviation correspondence வரைக்கும் மட்டும்தான் இருக்கும். 3 standard deviationும் -3 இருக்காது. So 3 standard deviation correspond to 99th percentile and -3 correspond to 1st percentile. So இது ரெண்டு வந்து இருக்காது. Okay. So this is the relationship between percentile chart and standard deviation chart. So next, how to interpret these values? இதோட growth chart முடிஞ்சிரும். How to interpret these values? நமக்கு தெரியும் from -2 standard deviation ல இருந்து +2 standard deviation வரைக்கும் நார்மல். ஓகேவா? So இதுல வர எல்லாமே வந்து நார்மல். Anything comes in this is normal. Okay. So if the weight for age is less than -2 standard deviation, it is underweight. If it is less than -3 standard deviation, it is severely underweight. Okay. Right. Height for age. If height for age is less than -2, it is called as shunting. The terminology is shunting. If it is less than -3, it is severe shunting. இது வந்து weight for height. Weight க்கு height க்கு. We'll take weight in x-axis and height in y-axis. Okay. So அப்படி போடுறப்ப this is called as wasting. This is called as wasting. If it is less than -2, if it is less than -3, it is severe wasting. Okay. So இது அதிகமா இருக்கு அப்படின்னா we have to use the BMI chart here. We have to use the BMI chart here. That is, this is BMI chart. So BMI chartல again more than 1 standard deviation இருந்தாலே risk for overweight. இது வந்து more than 2 standard deviation is overweight. Above 3 standard deviation is obesity. So this is the interpretation of the growth chart. Okay. So growth delay la only remember this thing, height age, bone age, chronological age oda relation. Height age அப்படினா 4 வயசுக்கு height age. Let us keep the height is 100 cm. 100 cm எந்த வயசுல வரும்? 4 வயசுல வரும். அதான் height age. Bone age will see with the ossification centers using X-rays. Chronological age, what is the date of birth ல இருந்து என்ன age வருதோ அது chronological age. So we have three important parameters for three important entities of growth delay. One is constitutional growth delay. அதாவது இடியோபதிக் யாருக்கிட்டே தெரியாது. Second is familial growth delay. Parents will be short, அதனால short. Third is growth hormone deficiency. So how will we relate this height age, bone age and chronological age? In these three things we have to remember. Constitutionalல வந்து height age உம் bone age ஈக்குவலா இருக்கும், whereas it will be less than that of chronological age. Familialல height age will be less than that of bone age, whereas bone age உம் chronological age உம் ஈக்குவலா இருக்கும். Growth hormone deficiencyல height age இருக்கிறதுலே கம்மி, bone age அதோட கம்மி, chronological age தான் இருக்கிறதுலே அதிகம். So this is very easy to remember of growth delay. Okay. Development, again we have 4 domains of development: gross motor, fine motor, language, social. I have given a table easy to remember. Till 2 years of age, the table la irukka normal developmental milestones நீங்க படிச்சுக்கோங்க with significance ஓட. It is just easy. Important milestones only I have told. You can't remember everything, right? So only important things you remember. That is enough. Common what question they will ask is the drawing skills they will ask. இந்த இதுல வந்து scribbles, when the child starts scribbles line 2 years of age, circle 3 years of age, cross, rectangle, square 4 years of age, triangle 5 years of age, diamond 6 years of age. Okay. So it is very easy. Scribbling line 2 years, circle 3 years, cross, rectangle, square 4 years, triangle 5 years, diamond 6 years. Okay. Remember this bomba. So milestones of 3-year-old child. I don't know why they are fond of this question. The milestones of a 3-year-old child, they will ask. So remember all in three. All in three. 3-year-old child can take a tricycle. It can cross the bridge of 3 cubes. It can take 3 objects with it. It can count 3 numbers. It can tell its age and sex. Again, age moved 3 letters. And sex is 3 letters. It can tell its age and sex. It can hop. It can hop. It can put the shoes on. Put on the shoes and unbutton the shirt. Unbutton the shirt. So shirt shirt போடுறது வந்து 4 years. So first is unbuttoning the shirt, second is buttoning the shirt. Okay, so remember this milestones of a 3-year-old child. Okay. அடுத்து developmental question. So these two formula you have to remember. Development DQ is average age of attainment divided by observed age of attainment into 100. So normally neck folding 3 மாசத்துல வரணும். நமக்கு 6 மாசத்துல தான் வந்திருக்குது into 100. Okay, so this is developmental question. So developmental question நீங்க எவ்வளவு வரும் 50% தான் வரும். So 50 anything less than 70% is delay. Anything less than 70% is delay. So this is developmental question. Intelligent question is mental age by chronological age into 100. This is intelligent question. Okay. So the last thing I want to tell is sexual development. இதுல இந்த ஒரே ஒரு டேபிள் மட்டும் you remember. The onset of sorry. The onset of puberty in male child is at 9.5 years. This is the exact number given in Nelson. Range எல்லாம் கிடையாது. 9.5 years is the onset of male puberty, and female it is 8 to 12 years. Okay, but for male they had given only one number, 9.5 years. I don't know why. So the first sign of male puberty is testicular enlargement, whereas the first sign in female is appearance of breast bulge, that is telarchy. So the order of changes in male is testicular enlargement, followed by scrotal pigmentation and penile growth, followed by growth spurt, followed by pubarchy, that is pubic hair. So this is the order of changes in the male. Female first is telarchy, second is growth spurt, third is pubarchy, that is pubic hair development, and fourth is menarche. Okay. So precocious puberty எப்ப சொல்லுவோம்? If a male child is having the sexual changes before 9 years of age, or the female child is having these changes, so here it is 8 years of age. Telarchy before 8 years of age, or menarche before 10 years of age is precocious puberty. Okay. Maximum age limit, that is when will you call it as delayed puberty in male? After 14 years அப்புறமேட்டும் no sexual development, it is delayed puberty in male, whereas in female after 13 years telarchy வரல, or 16 years அப்புறம் menarche வரல, or telarchy வந்து 5 வருஷமாயும் menarche வரல அப்படின்னா it is delayed development. They can ask anything from this. Okay, so 13 years, 16 years, or 5 years gap between 2. So you have to remember this. So the next topic what we are going to see is the nutrition. Malnutrition. Malnutrition is a broad terminology including undernutrition, overnutrition, nutrition, selective nutritional deficiency, vitamin A deficiency, B deficiency, எல்லாமே வந்து malnutrition குள்ள தான் வரும். So malnutritionல the most common concentrate பண்ண வேண்டிய ஏரியா வந்து protein energy malnutrition. The terminology is now changed into SAM, that is severe acute malnutrition. Okay. So because of decreased calorie intake and decreased protein intake, we will be having the features of malnutrition. So these are all the parameters we have to remember. So the child will be having visible severe wasting, or edema of both the feet, or weight for height less than -3 standard deviation, and or the midterm circumference of less than 11.5 centimeter. So இது நாலும் ஞாபகம் வச்சுக்கணும் for severe acute malnutrition. So if the baby is less than 6 months old, if the baby is less than 6 months old, in the midterm circumference criteria வந்து no need to use, because midterm circumference வந்து 6 months to 5 years வரைக்கும் தான் நம்ம எடுப்போம். 6 months to 5 years. So less than 6 months, if you want to find out the malnutrition, we can severe wasting irundha podum illa edema irundha podum illa weight for height less than -3 irundha podum, we can tell it as severe acute malnutrition. Okay. So what is this picture? This is marasmus. This is kwashiorkor. So what is the major difference in the look? It is because of edema. So the major difference in the look is because of edema. We'll see. So what is the major things in marasmus and kwashiorkor? The theories is 2 theories we have to remember. We'll clear it is in. So because of decreased calorie intake, what will happen? We won't be having insulin. Calorie adhima irundha da insulin adhima venum anabolic. So calorie illa, there is less insulin. So insulin kammiya irukradhanaala catabolic hormone cortisol will be more. So what will happen? This catabolic hormone will go and break all the somatic tissue, will break the tissue, and it will release. It will cause muscle wasting. So because of tissue breaking, we will be getting muscle wasting, and it is mainly happening to release glucose for the normal function, right? So we'll be getting glucose in the blood, and there will be release of amino acids in the blood. Okay. So the albumin level will be normal in blood, and there won't be any increased beta lipoproteins because there already we have enough amount of proteins in the blood. So beta lipoproteins will be less. So we won't be having the liver involvement in this scenario. Okay, the liver is completely protected in this scenario, and there is no edema, there is no fatty liver. Okay. So we can tell in a simple term, this is good adaptation to a poor diet. Good adaptation to a poor diet is marasmus. Good adaptation to a poor diet is marasmus. Whereas what will happen in kwashiorkor is there will be decreased calorie intake, but instead of decreased insulin, we will be having increased insulin because of unknown reasons. So what will happen? Opposite. Cortisol will be less. So less catabolic hormones. Somatic tissues, nothing will happen to our somatic tissue. It will be completely protected. So muscle wasting, glucose amino acids, there is no muscle wasting, there is no glucose in the blood, there is no amino acids in the blood. So what will happen? So liver has to work more. There will be a damage of the liver. Adanala liver has to synthesize more of proteins. So bad cholesterol, bad proteins, beta lipoproteins will be more. So albumin kammiya irukum, beta lipoproteins adhigama irukum. Appo enna agum? We will be getting edema and fatty liver. So this is maladaptation to a poor diet.
Sir, why there is an increased beta lipoprotein, sir?
Because of hello, I can't hear you. Someone is speaking.
Sir, beta lipoprotein எதனால sir increased ஆ இருக்கு?
Beta lipoprotein வந்து so we don't நம்ம கிட்ட bloodல protein இல்ல. Tissue break ஆகி protein வந்தாதான் protein. இந்த இடத்துல tissue break ஆகல. So liver தான் அதிகமா வேலை செஞ்சு protein produce பண்ணும். So liver நால produce பண்ண முடிஞ்ச proteinல ஒரே ஒரு protein இன்ஸ்டன்ட்டா கிடைக்கணும்னா lipoproteins தானே.
Sir, அங்க எல்லாமே break ஆகுதுல sir, அப்ப அங்க எப்படி sir beta lipoprotein?
Dear friends, sorry for disturbance. Dr. Anton here, please don't disturb. So many questions will prevent you to finish the lecture. Okay. I will add the Dr. Pradeep in group. You can get our doubts cleared because the exam date has been finalized. 11th and 12th is the exam date. Okay. I request you to go with the points and the content rather than too much of concept because time is short. Sorry for
Okay,
interrupting, Pradeep.
Yeah, sir. Okay, sir. Okay, sir. Madam, you can ask the question in the group, ma'am. We'll answer you.
Okay, okay.
Thank you. So a good adaptation to a poor diet is marasmus. Small adaptation to the poor diet is kwashiorkor. So this theory is called Gopalan's theory. This theory is called Gopalan's theory. We have one more theory for the marasmus and kwashiorkor. That is free radical theory. It is Golden's free radical theory. The concept behind this is because of increased free radicals, the iron transport in the cell membrane will be disturbed. So adanala edema varum அப்படிங்கிறது வந்து free radical theory. So free radicals will cause decreased iron transport, that will cause edema. That is Golden free radical theory. These are two common theories of malnutrition. So edema, fatty liver, skin manifestations are more in kwashiorkor, whereas it is less in marasmus. Okay, so this is we have to remember, and this difference again I had given in the material. Appearance here it is old man appearance, here it is sugar baby or moon faces appearance. Age group, this again is more common in less than 1 year of age. This is more common in 2 to 5 years of age. prevalence marasmus is most common, the most common, whereas kwashiorkor is less common. இங்க வந்து mood of the baby will be normal, whereas இங்க வந்து mood of the baby will be irritable or lethargic because of hypoglycemia. இங்க sugar கம்மியா இருக்கும் because of hypoglycemia. Appetite, here it will be a normal appetite, whereas here it will be of altered appetite. This again I have told, infections are more common in kwashiorkor compared to, more common in kwashiorkor compared to marasmus. ரெண்டு பேருக்கும் இருக்கும், but less in marasmus. Skin and hair changes are more common in kwashiorkor. Skin la வந்து to remember phrenoderma is a skin condition with and crazy paint dermatosis. Other altered colors, crazy paint dermatosis is common in skin, whereas hair la வந்து flag sign அப்படினா வந்து normal hair அப்புறம் white hair அப்புறம் normal hair, so அந்த மாதிரி flag sign, that is more common in kwashiorkor. Treatment response will be good for marasmus, whereas poor for kwashiorkor. Okay, so this is the common thing we have to remember here. The complications of protein energy malnutrition வந்து hypoglycemia, I have told, remember it as sugar, hypoglycemia, hypothermia, infection. Infection is why? Because of decreased NK cell activity, decreased phagocytosis, decreased complement activity, decreased T cells. இதெல்லாம் குறையும். Remember B cell activity நல்லா தான் இருக்கும். So B cell நார்மலா இருக்கிறதுனால we can give normal vaccinations for a malnourished children. So இந்த क्वेश्चन கேட்பாங்க, vaccination for a malnourished children கொடுக்கலாமா கொடுக்கூடாதா? எல்லா immunity குறைஞ்சிருக்கும் except B cell immunity. So we can give vaccination normally for the malnourished child. Electrolyte imbalances, sodium potassium தான் மெயினா ஆல்டர் ஆகும். Hypernatremia and hypokalemia will be there. Dehydration, I will tell about the dehydration because ORS syllabusல இருக்கு. ORS தனியாவே கேட்பாங்க அப்படின்னு கொடுத்திருக்காங்க. We'll see. Deficiency, iron, vitamin A, micronutrient deficiencies will be there. Okay. So classification of dehydration. So ADD dehydration classification கேட்பாங்க. We have three things: no dehydration, some dehydration, severe dehydration. Usually we have four signs to assess this dehydration: sensorium, eyes of the baby, thirst of the baby, and skin pinch of the baby. So sensorium in no dehydration will be a well alert child, whereas some dehydration it will be restless and irritable child. Severe dehydration it will be lethargic and unconscious child. Okay. Eyes no dehydration la normal ah irukum. Some dehydration la sunken eyes irukum. So remember this sunken eyes will be there in some dehydration itself. So sunken eyes appadina severe dehydration ella nanachirupanga, but it's not. Sunken eyes will be there in some dehydration itself. Thirst no dehydration la normal ah irukum. Some dehydration la it will be a thirsty baby. The baby will drink eagerly, whereas in severe dehydration it drinks poorly. Okay, it will not be able to drink. Skin pinch normal, it will go back quickly in no dehydration, slow in some dehydration, very slow in severe dehydration. So treatment no dehydration, we have plan A, plan B for some dehydration, plan C for severe dehydration. So what is this plan A, plan B, plan C? We should be knowing. Plan A அப்படினா எல்லாமே ஓரதம். Plan A அப்படினா 10 to 20 ml per kg ORS with each loose stool. ஒரு வாட்டி loose stool போகும்போதும் we have to give 10 to 20 ml per kg of ORS for the child. That is plan A. It is home management. Plan B is we have to give 75 ml per kg ORS for 4 hours. Over 4 hours we have to give. This is in this period we have to keep the baby under observation. இது வந்து டே கேர்ல வெச்சு 75 ml per kg ORS for 4 hours குடிக்க வெச்சிட்டு again assess the dehydration. So it may go for no dehydration, it can stay in some dehydration, it can go for severe dehydration, right? So எந்த கேட்டகரியில வருதோ அந்த ட்ரீட்மெண்ட். Plan C is admission. Plan C is admission. We have to give IV fluids. The IV fluid of choice is oral. The IV fluid of choice is oral. How much we have to give is 100 ml per kg. 100 ml per kg less than 1 year ல எப்படி கொடுப்பாங்க, more than 1 year ல எப்படி கொடுப்பாங்கன்னு இருக்கு. So less than 1 year ல first 30 ml in 1 hour, remaining 70 ml in 5 hours கொடுக்கணும். Whereas After more than 1 year, the 30 ml in half an hour, whereas 70 ml in 2.5 hours. Half of this. Half an hour and 2.5 hours. So this is the treatment for dehydration. So ORS again they will ask. We have 3 different types of ORS. One is standard ORS, WHO ORS, and third thing is resomol. What is resomol? Resomol is the rehydration solution for malnourished children. This is SAM severe acute malnutrition special ORS. That is rehydration solution for malnourished children. Okay. We commonly use WHO ORS. So what is the osmolarity? They will ask. What are the contents? They will ask. So normal sodium, potassium, sodium chloride, potassium citrate, glucose. Okay, remember it as sodium chloride, potassium citrate, and glucose. So the osmolarity of WHO ORS is 245. So in the sodium potassium, 75, 65, 20, 10. Remember sodium chloride, potassium citrate, 75, 65, 20, 10. Okay. Glucose is sodium 75. Okay, so the total is 245 for WHO ORS. Whereas standard ORS it is 311. Standard ORS 311 because of sodium jastiya irukum, chloride jastiya irukum, glucose jastiya irukum. So equal potassium citrate equal irukum. This also they may ask. Okay. So why they changed from standard ORS to WHO ORS? Because previously the most common cause of diarrhea is cholera. It is osmotic diarrhea. We have to give more of glucose, more of sodium. Whereas now the most common diarrhea is rotaviral diarrhea, which is watery diarrhea. Hypoglycemia. So we have to give a reduced osmolar ORS, that is WHO ORS. Okay. Resomol persa ninga values la nyam vechukona. Overall osmolarity is 300, that you remember. But apart from this sodium chloride, potassium citrate, glucose oda serthi, it contains zinc, copper, magnesium. Zinc, copper, magnesium will be there in the resomol. So this we have to remember. Okay. Sorry. So most common questions they will ask. Most common age group of diarrheal disorders is 2 years, less than 2 years. Acute diarrhea abdina infective diarrhea for less than 14 days. Persistent diarrhea na infective diarrhea for more than 14 days. Chronic diarrhea abdina non-infective diarrhea for more than 14 days is chronic diarrhea. Dysentery abdina watery stools plus blood or mucus. Blood or mucus in this, it is dysentery. Okay, so this is common terminologies we have to know. Most common cause of acute diarrhea we know, that is rotavirus. So we are using rotavirus vaccine for the prevention. Most common cause of acute dysentery is Shigella. Okay, in pediatric age group it is Shigella, whereas in adults it is E. coli. Whereas in adults it is E. coli, pediatric it is Shigella. One more thing in severe acute malnutrition is refeeding syndrome. Because of aggressive feeding, we will get increased serum insulin level. So in the insulin level, we will be getting hypokalemia, hypophosphatemia, hypomagnesemia. It is because of physiology. If you have any doubts, we can discuss it later. Okay. So few questions to remember here is vaccines. I have already told we can give vaccine according to the normal universal immunization program schedule because B cell immunity is normal. Rickets, again there is no rickets in protein energy malnutrition because rickets is a disease of growing bones. Bone valaradhu because of malnutrition. So we won't get rickets in severe acute malnutrition. Iron supplements we have to start after 2 weeks. So first 2 weeks of stabilization phase la iron kuduka kudade. Dehydration we know the synchronized sensorium, thirst idella. So normally the malnourished baby ki summave ice tankana da irukum, summave sensorium altered da irukum. So that and all is not reliable dehydration signs in a malnourished baby. So the reliable sign is thirst. We can assess with urine output. urine output is decreased, it is dehydrated. We can assess with heart rate. If it is tachycardia, we can consider it as dehydration. So synchronized sensorium we won't use as a dehydration sign in malnourished child. Okay. So Ricketts curve just this X-ray findings they will ask. I'll finish with this. Okay. So Ricketts starting from the diaphysis, the first sign will be bending of long bones. Long bones bend down. There will be a thinned out cortex, pencil line cortex will be there. Metaphysis, there will be a metaphyseal widening will be there. Appo the moonu nyavasham cupping, fraying, splaying. Fraying அப்படின்னா margins of metaphysis என்ன ஆகும் அப்படின்னா இந்த ஷார்ப் பார்டர்லாம் இந்த மாதிரி ஃப்ரே ஆயிரும். ஸோ ஒரு மாதிரி it will get eroded. Okay. So because of fraying, this bone will get weak. அதனால pressure வரும்போது there will be cupping. Okay, cupping ஆகும்போது it will get splay. It will splay on both the sides. Okay, so this fraying, cupping, splaying is very specific of rickets. Epiphysis la flaring, that is widened epiphysis is called as flaring of epiphysis, and there will be increased gap in the metaphysis and epiphysis. X-ray picture கொடுத்து கேட்பாங்களான்னு தெரியல, but they may mention these the names and they will ask. Okay, that the best X-ray for the assessment of rickets is X-ray wrist. Wrist joint is best to. Yeah. That's it. Okay. The second thing what we have to know is scurvy. Scurvy X-ray. Okay. So the typical radiographic changes we have to see in knee joint. For rickets, it is wrist joint. For scurvy, it is knee joint. So idhula irukka specific enna ground glass opacities in the diaphysis. Ground glass opacities in the diaphysis. Again, pencil thin cortex will be there. There will be a calcified cartilage in the metaphysis. The metaphysis la calcification ogarum. Aduk per enna, that will appear as a white line. That is called as white line of Frankel. And epiphysis la ade sclerosis ayi calcification aganala there will be a sclerotic ring. So this ring is called as Wimberger sign. Wimberger sign is in epiphysis. White line of Frankel is in metaphysis. Okay. And the metaphysis la elongation of this white line outside this metaphysis, that is called as Pelton's spur. So remember this Pelton's spur, and there is a rarefaction under this white line. The white line க்கு கீழ இருக்க calcification of white line இருக்கும், அதுக்கு கீழ ஒரு fraying இருக்கும், அதுக்கு பேர் தான் Rummerfeld zone. And we can see a subperiosteal pathological bleeds also in scurvy. Okay. So these finishes rickets and scurvy and common nutritional things. And this difference I want to tell. Ricketic rosary is the blunt angulations in the ribs, whereas scorbutic rosary will be sharp angulations in the ribs. This is not painful, whereas scorbutic rosary will be very painful. Okay. So this is the major difference between ricketic rosary and scurvy rosary beads. Okay, the reliable sign for the assessment of dehydration in the SAM child.
Urine output.
Answer.
C.
Urine output, sir.
Yeah, it is decreased urine output because the baby will be having synchronized lethargy, skin pinch because of loss of subcutaneous fat. The skin pinch will normally go back slowly. So all these are not reliable in the case of severe acute malnourished child. Okay, very good. So we'll take a 2 minutes break. It's not 5 minutes. We are late in our schedule. You can see this question in that time. யாருமே ஆன்சர் சொல்லல. Nobody wants to try. This little difficult question. Okay. The answer is transvenous device closure. So we'll see the cardiac things. Actually, we'll see. We'll start from the fetal circulation. This is very complicated fetal circulation. We'll simplify it. We'll see all the diseases in this box. We can finish it in some 15-20 minutes. Okay. So this is right atrium, this is right ventricle, and this is left atrium, and this is left ventricle. SVC, IVC will empty into right atrium. From right atrium will go into tricuspid, via tricuspid valve, it will go into right ventricle. From right ventricle, it will go into pulmonary artery. That is deoxygenated blood. Oxygenated blood lungs la irundhu pulmonary veins valiya left atrium porum, left atrium la irundhu mitral valve valiya left ventricle ku povum, left ventricle la irundhu aorta valiya veliya povum. This is very basic, we all know. Okay, so what will happen in fetal circulation? Ulla vandu when the baby is inside the mother's uterus, lungs vela seiyadu. So who is doing that function of lungs? That is placenta. So lungs la irukka blood vessels placenta la irukka blood vessels equal. That is pulmonary veins umbilical veins equal. Umbilical vein will carry oxygenated blood, right? So pulmonary artery umbilical artery equal. This will carry deoxygenated blood. Artery will carry oxygenated blood, but pulmonary artery will carry deoxygenated blood. Umbilical artery also will carry deoxygenated. Okay. So lungs is not functioning. So fulla vandu it is filled with fluid. It is very stiff. So pulmonary vascular resistance is very high. Okay, so pulmonary vascular resistance is the high resistance, whereas this is systemic circulation. Systemic vascular resistance is very low resistance before birth. So after birth, so this is fetal circulation. First placenta la irundhu umbilical vein valiya oxygenated blood liver ku povum. Liver la irundhu it is shunted to ductus venosus. So in the junctions they may ask, okay, via ductus venosus it will enter IVC. IVC la irundhu it will empty into right atrium. From right atrium it will go into left atrium because oxygenated blood systemic circulation left heart go. So via foramen oval it will enter left atrium. Left atrium la irundhu left ventricle ku vandrum. Left ventricle la irundhu aorta. Aorta la irundhu it will go into the all parts of the body. Okay. So upper half and lower half of the body. So SVC la irundhu deoxygenated blood right atrium ku varum. SVC la irundhu deoxygenated blood right atrium ku varum. But there is a thing that is called as crista dividens. It won't allow the right atrium to mix the oxygenated and deoxygenated blood much. Okay. So in the deoxygenated blood அப்படியே bypass ஆகி right ventricle க்கு வந்துரும். Okay. So that crista dividens the mass the right ventricle la irundhu again pulmonary artery க்கு வழியா lungs க்கு போகும். But our lungs is not functioning now, right? So pulmonary artery la irundhu enga போகும்? Via PDA, via ductus arteriosus it will go into aorta. So lower half of the body க்கு இன்னும் deoxygenated blood தான் போகும். Upper half of the body brain க்கு blood போகணும். That is very good blood. கீழ போறது still more deoxygenated blood. இங்க இருந்து umbilical vein வழியா again it will go into placenta. So this is the very basic fetal circulation. Okay. So we have three important shunts. One is ductus venosus, second is foramen oval, third is ductus arteriosus. So these three shunts we have to remember. So what transition will happen after birth? Baby will start breathing. Lungs kulla air ponone fluid ella veliya vandrum. So fluid ella veliya vandadukku apra enna agum? வெறும் ஏர் தான் இருக்கும். ஸோ பல்மரி வாஸ்குலர் ரெசிஸ்டன்ஸ் ஃப்ளூயிட் இருக்கும்போது அதிகமா இருக்கும், வெறும் ஏர் மட்டும் தான் இருக்கும்போது it will fall rapidly. So pulmonary vascular resistance after birth is very low. Okay, so what are the other things will happen? பிளாசண்டாவை எடுத்துருவோம், அம்பிளிக்கல் வெயின் டிசப்பியர் ஆயிரும், டக்டஸ் வீனோசஸ் என்னவா மாறும், லிகமெண்டம் வீனோசமா மாறிடும். ஐவிசில ஒன்லி டீஆக்சிடேட்டட் பிளட் தான் போகும். ஸோ ரைட் ஏட்ரியம்ல இருக்க எல்லா கன்ஃபியூஷன்ஸும் போய் ரைட் ஏட்ரியம்ல ஒன்லி டீஆக்சிடேட்டட் பிளட் தான் இருக்கும், அது ரைட் வென்ட்ரிகிளுக்கு போயிடும். ரைட் வென்ட்ரிகிளுக்கு போனதுக்கு அப்புறம் லங்ஸ் எக்ஸ்பேண்ட் ஆகும். லங்ஸ் எக்ஸ்பேண்ட் ஆன உடனே பல்மரி ஆர்டரியில இருந்து லங்ஸுக்கு பிளட் போயிடும். ஸோ டக்டஸ் ஆர்டரியோசஸ்க்கு வேலை கிடையாது. டக்டஸ் ஆர்டரியோசஸ் வில் சேஞ்ச் இன்டு லிகமெண்டம் ஆர்டரியோசம். ஸோ அயோட்டால கம்ப்ளீட்லி ஆக்சிடேட்டட் பிளட் மட்டும் தான் வரும். ஓகே, ஸோ திஸ் இஸ் த சேஞ்சஸ் தட் அக்கர்ஸ் ஆஃப்டர் பர்த். அண்ட் foramen ovale because of increased systemic pressure, இந்த பக்கம் லெஃப்ட் ஹார்ட்ல பிரஷர் பில்டப் ஆகிறதுனால என்ன ஆகும்னா foramen ovale க்ளோஸ் ஆயிடும். ஓகே, so these are all the transition happens after birth. இந்த क्वेश्चन தான் நம்ம பார்த்தோம். we'll see. So first we'll start with PDA.
அவர் கிளம்பிட்டாராங்க.
PDA ல என்ன ஆகும் அப்படினா PDA ல என்ன ஆகும் அப்படினா ஏடிஎம்ல blood வருது, லெஃப்ட் வென்ட்ரிகுலர் blood வருது. PDA is the left to right shunt. Remember இந்த shunt எல்லாம் எந்த டைரக்ஷன்ல இருந்து எந்த டைரக்ஷன் கேட்பாங்க. So we know pulmonary circulation is low resistance, systemic circulation is high resistance after birth. So high resistance ல இருந்து low resistance தான் blood போகும். So it is left to right shunt. PDA is a left to right shunt. அங்க இருந்து blood எல்லாம் எங்க போகும், லங்ஸ்க்கு போகும். லங்ஸ்ல இருந்து மறுபடியும் லெஃப்ட் ஹார்ட்டுக்கே வரும். So left heart is receiving more blood. எங்கெல்லாம் டபுள் ஆரோ இருக்கோ அங்கெல்லாம் more blood. So left heart is receiving more blood. Okay, so இதுல எங்க வந்து ஹைப்பர்ட்ரோபி வரும்னு கேட்பாங்க. ஒரு ஸ்டேட்டுக்கு மேல லங்ஸ் ஓவர்ஃப்ளோ ஆயிடுச்சு அப்படின்னா there will be a back flow of blood in the pulmonary artery. Back flow of blood in the pulmonary artery. So back flow ஆச்சு அப்படின்னா என்ன ஆகும், அதுக்கு மேல pulmonary arteryல blood போக முடியாது. So there will be opposite shunt, reversal of shunt from right to left side. We have to so the left to right shunt, right to left மாறதுக்கு பேரு, அதாவது cyanotic heart disease acyanotic heart disease மாறதுக்கு பேரு தான் வந்து ஐசன்பெர்கர். ஓகே, so cyanotic heart disease acyanotic heart disease மாறதுக்கு பேரு ஐசன்பெர்கர் syndrome. so PDA ல என்ன பார்க்கறோம், so இது வந்து rapid revision for the last minute. PDA is left to right shunt and it is increased pulmonary blood flow, this we know. PDA is more common in preterm, PDA is more common in female. Okay, preterm PDA will close on its own, whereas term PDA will never close on its own. This we have to remember. Symptoms நமக்கு தெரியும். Features of increased pulmonary blood flow. Features of increased pulmonary blood flow என்னன்னா recurrent respiratory infection, exertional dyspnea, atelectasis, failure, இதெல்லாம் features of increased pulmonary blood flow. Signs PDA ல என்ன வரும்னா we will be having a bounding pulse, hyperactive precordium because of left heart க்கு அதிகமா blood வருது. There will be a paradoxical split, reverse split. நார்மலா A2 P2 தான் வரணும், இந்த பல்மரிக்கு தான் அதிகமா blood போகுது, அதனால என்ன மெசேஜ் A2 ஆகும். ஓகே, can you please mute? Hello, somebody is speaking. Please mute. Okay. And the typical murmur in PDA is continuous murmur. It is called as continuous murmur, Gibson's murmur, machinery murmur, train in tunnel murmur. So இதெல்லாம் வந்து Gibson's murmur ஓட வேற பேர். They may ask in any name. Okay. We will be getting differential cyanosis. Why? Because the upper part of the body is supplied with oxygenated blood, whereas lower part of the body is getting less oxygenated blood. அதனால there will be differential cyanosis. P2 louder இருக்கு அப்படின்னா there will be pulmonary hypertension develop ஆயிடுச்சுன்னு அர்த்தம். So that pulmonary hypertension develop ஆகிறது தான் வந்து ஐசன்பெர்கர் syndrome what we saw. Okay, so X-ray ல we will be having left atrial dilatation, left ventricular dilatation, arch of aorta dilatation. All these things will be there, and there will be a pulmonary plethora. A plethora is increased blood flow in the lungs. Okay, so treatment babies we have to give prostaglandin antagonist, indomethacin, ibuprofen, paracetamol இதெல்லாம் கொடுத்து க்ளோஸ் பண்ணலாம். whereas PDA திறந்து வைக்கணும் அப்படின்னா what we have to give, prostaglandin analog, that is alprostil. The drug pair is alprostil. So this we have to remember. Surgical closure வந்து okay, I will tell the size. Small PDA is less than 1.5 mm. 1.5 mm ல இருந்து 3 mm is medium. More than 3 mm is large. Okay, more than 3 mm is large. So less than 3 mm இருக்கு அப்படின்னா we can do a coil closure. 3 to 12 mm இருக்கு அப்படின்னா we can do a amplifier closure. 12 mm க்கு மேல இருக்குன்னா we have to do a septal closure. All these closure we have to surgical procedures we have to do within 1 year of age. Okay, right. The second disease is VSD. VSD யும் PDA வும் almost equal. VSD யும் PDA வும் almost equal. என்ன இங்க ஷண்ட் ஆவறதுக்கு பதிலா இங்க மேலேயே ஷண்ட் ஆயிரும், அவ்வளவுதான். So we'll be having a large ventricular septal defect. இதுவும் left to right shunt தான், because left side pressure கம்மி, right side pressure கம்மி, left side pressure ஜாஸ்தி. So blood will go from left to right. One beauty here we have to remember is this blood will not stasis in the right ventricle, because left ventricle right ventricle simultaneously contract ஆவறப்ப blood இங்க நிக்காது. So இங்க இருந்து contract பண்ண உடனே இந்த blood இங்க வந்து அப்படியே main pulmonary artery போயிடும். So the thing behind this is we won't get right ventricular hypertrophy here. நம்ம என்ன நினைப்போம் அப்படின்னா the right ventricle, the blood main pulmonary artery போய் லங்ஸ்க்கு போய் லெஃப்ட் ஏட்ரியம் வந்து லெஃப்ட் வென்ட்ரிக்கிளுக்கு வந்து ரைட் வென்ட்ரிக்கிளுக்கு வந்துச்சுன்னா ரைட் வென்ட்ரிகுலர் ஹைப்பர்ட்ரோஃபி இருக்கும் நினைப்போம். பட் there is no right ventricular hypertrophy in VSD. Okay, so that we have to remember. Clinical features we'll see. The same thing will happen here. Once the lungs gets overflowed, what will happen? There will be backflow of blood in the main pulmonary artery. So we will be getting pulmonary hypertension. Because of pulmonary hypertension, we will be getting right to left shunt. So right to left shunt தான் வந்து இது Eisenmengerization. So this is Eisenmenger syndrome in VSD. And remember, large VSD will not make any sound. This is again very important. Only small VSDs will make sound. Large VSD is silent. Large na size. So size again less than 3 mm is small. 3 to 6 mm is medium. More than 6 mm is large. Okay, VSD size la வந்து 3 mm கீழனா small, 3 to 6 is medium, more than 6 is large. Okay, so in the left to right shunt, right to left மாறது தான் Eisenmengerization. So VSD la important things again left to right, increased pulmonary blood flow. This is the most common acyanotic congenital heart disease we have to remember. Again, it is more common in female, more common in infant of diabetic mother. I have told when we are discussing about IDM. So we have different types of VSDs. And again, the clinical features will be same as that of increased pulmonary blood flow signs. So here, bulging pericardium, hyperactive pericardium, wide split, thrill, murmur in the left lower sternal area la murmur. Okay, so P2 again loud P2 கேட்ச்சு அப்படின்னா shunt reverse ஆயிடுச்சுன்னு அர்த்தம். It is Eisenmengerization. So X-ray la I have told left atrial hypertrophy, left ventricular hypertrophy, main pulmonary artery hypertrophy. Remember, right ventricle வந்து நார்மலா தான் இருக்கும். There is no hypertrophy of right ventricle. Okay, so small VSD, muscular VSD எல்லாம் வந்து spontaneous closure ஆகும். Within 6 months குள்ள அதுவே க்ளோஸ் ஆகும். ஒருவேளை ஆகல அப்படின்னா we have to go for surgery. And Swiss type of VSD will never close. Remember, never close. Swiss type of VSD will never close. So indication for surgery, we have to remember 4 things. In the knowledge important, they may ask anything. So large VSD will never close. We have to do surgery. Symptomatic VSD will never close. We have to do surgery. Inlet and outlet type of VSD will never close. We have to do surgery. And this pulmonary artery pressure is more than 50% of systemic pressure. அதாவது QP-QS ratio வந்து more than 2:1. QP-QS ratio is more than 2:1 na, it will never close. We have to do surgery. So இதுதான் the question. What was asked in that question? No, it is QP-QS ratio of more than 2:1 is indication for surgery in VSD. QP-QS ratio of more than 1.5:1 is indication for surgery in ASD. Okay, இங்கே படிச்சலாம். So this is indication for surgery in ASD. So this finishes VSD. So ASD again same pathology. என்ன VSD க்கு மேல ஒரு ஸ்டெப் atrial septal defect. இதுவும் left to right shunt தான். Right atrium blood நிறைய வரும், right ventricle நிறைய வரும், main pulmonary artery வரும். Again it will go back to lungs. again the same thing. It won't stay in the left atrium. It won't stay in the left atrium. It will directly go into the right atrium. So left atrial hypertrophy varadu normal da irukum. So no left atrial dilatation. And there is no direct transmission of pressure. So எல்லா இடத்துலயுமே main pulmonary artery க்கு pressure direct transmission ஆச்சு PDA ல இருந்து VSD ல இருந்து, whereas ASD ல இருந்து இங்க வந்து அப்புறம் இங்க வந்து தான் வரும். So pulmonary hypertension வரணும் அப்படின்னா it will take decades. Pulmonary hypertension Eisenmerization ASD ல வரதுக்கு ரொம்ப லேட் ஆகும். Okay, so that we have to remember here. So murmur is not due to ASD. ASD will not make any murmur. It is because of flow murmur in the tricuspid valve. So relative pulmonary stenosis nala ESM varum, relative tricuspid stenosis nala MDM varum. It is not because of ASD. Okay. So ASD features are left to right shunt, increased pulmonary blood flow, female la most common types we have told. Symptoms same, increased pulmonary blood flow symptoms. Idhula vandu wide fixed slit in ASD. Okay. And ASD is a silent shunt, we have to remember. Murmur I have told, and pulmonary hypertension and Eisenmerization is very rare. If it is occurring, it will be very late. Okay. So cardiomegaly is right atrium, right ventricle, main pulmonary artery. Never left atrial hypertrophy. All of ASD முடிஞ்சிச்சு. So ASD la the size ஞாபகம் வச்சுக்கோங்க. Spontaneous closure less than 8 mm. Again, size சொன்னோம் அப்படின்னா ASD வந்து 6 to less than 6 mm is small. 6 to 12 mm is medium, more than 12 mm is large. So it is again easy. Okay, PDA size சொல்லியாச்சு, VSD size சொல்லியாச்சு, ASD size சொல்லியாச்சு. So ASD of less than 8 mm is will go for spontaneous closure within 4 years of age. நம்ம ASD க்கு 4 years வரைக்கும் வெயிட் பண்ணலாம், whereas VSD க்கு 6 months குள்ள க்ளோஸ் ஆகும். Okay, spontaneous closure 6 months குள்ள ஆகும். The failure, pulmonary hypertension, இதெல்லாம் வந்து third decade of lifeல தான் வரும். Surgical indications அதே 4 பாயிண்ட் தான். Large ASD, symptomatic ASD, ostium primum type of ASD, and this pulmonary artery pressure more than 50% of systemic artery pressure. That is QP/QS ratio of more than 1.5:1. This we have told. So this finishes ASD. Okay. So this is a common thing, AV septal defect. It is also called as this combination of all ASD, VSD, abnormal AV valve. Okay, the AV septum full away defective. Okay, so it is also called as AV canal defect or endocardial cushion defects. This கேள்விப்பட்டிருப்பீங்க நினைக்கிறேன், endocardial cushion defects. So this is more common in Down syndrome. So இதுதான் கொஸ்டின். Down syndromeல most common congenital heart disease அப்படின்னு கேட்டாங்கன்னா endocardial cushion defects. It is more specific for the Down syndrome. So these are the common things in PDA, VSD, ASD. எல்லாமே common in female. எல்லாமே increased pulmonary blood flow causing recurrent respiratory tract infection. Reversal of shunt எல்லாத்துலயும் வரும். Eisenmenger syndrome more common in PDA followed by VSD followed by ASD. Infective endocarditis again more common in VSD followed by ostium secundum type of ASD. Okay. So all these are volume overloaded lesions. Okay. So this we finished. Next ஒரே ஒரு pressure overloaded lesion, அது coarctation of aorta. Questions மட்டும் பார்த்தறலாம். Coarctation of aorta நமக்கு தெரியும். So coarctation அப்படினா வந்து it's just angulation of aorta or constriction of aorta, usually at the junction. It is the most common site is juxta ductal, that is ductus arteriosus adjacent இருக்கும். Juxta ductal is the most common site. Okay, so this is constriction of aorta. Obstructive lesion. So in the obstructive lesion la, this is ascending aorta, this is descending aorta, this is constriction, this is ductus arteriosus. Okay, so in the constriction கீழ இருக்கிற aorta வந்து இப்படி dilate ஆகும். அதனால we will be getting a 3 sign. This is called as 3. So this we will be getting a 3 sign in the X-ray. So this is a pathognomonic X-ray finding in the coarctation of aorta. Okay, because of post-stenotic dilatation. So coarctation la ஒரு question ஞாபகம் வச்சுக்க வேண்டியது Schoen complex. What is Schoen complex?
Recording in progress.
Complete left heart வந்து there will be having blocks. So left heart la first block is coarctation of aorta, இரண்டாவது block aortic stenosis, மூணாவது block mitral stenosis. Okay, மூணாவது block mitral stenosis. So shown complex contains mitral stenosis, aortic stenosis with coarctation of aorta. So this is the one-liner we have to remember here. So coarctation la it is an obstructive lesion, pressure overload lesion, more common in male. Remember, all are common in female. Coarctation is more common in male. Syndrome association is Turner syndrome. Okay. And features on the poor feeding, dyspnea, circulatory shock, left ventricular failure. All these are features of coarctation of aorta. Differential pulse and BP will be there. Lower limb la kammiya irukum because of constriction. And then the constriction வந்து எங்க வேணா இருக்கலாம். Aorta starting from ascending aorta till the bifurcation of iliac arteries வரைக்கும் எங்க வேணா இருக்கலாம். Most common is juxtaductal. Okay. So we will be getting radiofemoral delay. Differential cyanosis will be there. There won't be any split in S2. Okay. And no murmur in 50%. Okay. X-ray la audiomegaly will be there. 3 sign will be there. So this 3 sign I have already told. The coarctation kila blood irukadala. So collaterals will be formed. So the most common collaterals form agara idam inferior mammary artery. Most common collaterals form agara idam vandu inferior mammary artery, subclavian artery, and anterior spinal artery. So these collaterals we have to remember. And severe coarctation is duct dependent. Severe coarctation, we have to keep the ductus open. That is duct dependent. We have to give the drug alprostyn. Okay. So the treatment is definitive treatment is we have to do a resection and anastomosis of the coarctation of aorta. Enga constriction irukko adha cut pannite we have to do a end-to-end anastomosis of the aorta. This is the definitive treatment. This we finishes aortic congenital arteries. So now we can answer this question. The best management approach in a 10-year-old with ostium secundum atrial septal defect. 10-year-old le mudinjiruchu spontaneous closure agadu. We have to do a surgical closure. Again ASD la 3:1 shunt. ASD la shunt evlo more than 1.5:1 irundichu appadinale QPQS ratio. We have to do closure. So the answer is transvenous device closure. Okay. So CCHD la will see only one disease, that is tetralogy of Fallot. We have so many congenital cyanotic heart diseases. Remember it as 5T. That is tetralogy of Fallot, tricuspid atresia, transposition of three arteries, truncus arteriosus, and TAPVC. That is total anomalous pulmonary venous connection. 5 T's we have to remember. Epstein's anomaly and Eisenmenger syndrome. We have to remember 2 T's. Adilama 3 disease. One pulmonary atresia, single ventricle, hypoplastic left heart. So idella na congenital cyanotic heart disease. நம்ம இதுல ஒரே ஒரு இம்பார்ட்டன்ட் டிசீஸ் என்னன்னா tetralogy of Fallot. Tetralogy of Fallot ல வந்து what are the components of the tetralogy? 4 component நமக்கு தெரியணும். So let us draw our heart like this. This is pulmonary artery and this is aorta. Okay, so what are the components of tetralogy of Fallot? Always remember start with pulmonary stenosis. It is infundibular pulmonary stenosis. One pulmonary stenosis இருக்கிறதுனால blood வெளிய போகாது. So heart has to pump more. So right ventricular hypertrophy will be there because of increased work of right ventricle. So second component is right ventricular hypertrophy. Third component in the right ventricle irundhu blood veliye ponulla. So always it will be associated with VSD. Okay. So third component is VSD. Fourth component, there will be overriding of arch of aorta over this VSD. That is overriding of arch of aorta. So these 4 are the components of tetralogy of Fallot. So this you remember, please remember. One is always start with pulmonary stenosis, infundibular pulmonary stenosis. Second is right ventricular hypertrophy. Third is large VSD. This VSD in tetralogy of Fallot will be always large. Remember large VSD. Apro overriding of arch of aorta. So idhula enna symptoms varum? Is it duct dependent or not? Is it duct dependent or not? Because VSD irukku, adanal namak shunt thevilla. It is not duct dependent. Okay, it is not duct dependent. Second is VSD la murmur kekuma kekada. Remember what I told, it is large VSD. It is large VSD. Large VSD will not make any sound. So there is no murmur in tetralogy of Fallot. pulmonary blood flow என்னவும் pulmonary blood flow will be decreased because in the VSG ல right ventricle ல pulmonary stenosis இருக்கு, இந்த blood இருக்காது. So pulmonary stenosis ல இருந்து இங்க தான blood போகுது. So it is right to left shunt. Sorry, it is right to left shunt. So pulmonary blood flow is decreased. So what are the features of decreased pulmonary blood flow? There will be cyanotic film, there will be squatting episodes, there will be dyspnea on exertion, there will be pulmonary oligemia. Pulmonary oligemia அப்படினா lungs-ல blood இருக்காது. That is pulmonary oligemia. So these are all the features of pulmonary blood. Decreased pulmonary blood flow. Increased pulmonary blood flow அப்ப என்ன ஆகும்? Dyspnea on exertion. Lung will be overflowed with blood. So dyspnea வரும். There will be suck cycle will be there. Recurrent respiratory tract infections because of overflow of blood in the lungs. Okay. And here we will be getting pulmonary plethora in X-ray. That is big overflow of lungs. Overflow of blood in the lungs will be getting pulmonary plethora. So tetralogy of Fallot order box, it is right to left shunt. There will be decreased pulmonary blood flow. It is the most common cyanotic congenital heart disease. Most common acyanotic congenital heart disease is VSD. Most common cyanotic congenital heart disease is tetralogy of Fallot. It is most commonly associated with Dyejar's syndrome. Dyejar's syndrome. We have types of tetralogy of Fallot. I'll tell it later. The most common presenting symptom will be cyanotic spell. Usually it will present with cyanotic spell. We will be having bulging precardium because of right ventricular hypertrophy, hyperactive precardium, soft B2 because of pulmonary stenosis. Murmur வந்து VSD ல murmur கேட்காது. VSD ல murmur கேட்காது because of large VSD. ESM in the pulmonary area and PSM in the VSD area being acyanotic top. Okay. So chest X-ray la the most common finding is boot-shaped heart. Tetralogy of Fallot, boot-shaped heart. I will tell only X-ray findings of the other things. We will be getting boot-shaped heart in tetralogy of Fallot. Okay. So the treatment is we have to do a patch closure of this VSD followed by resection of the pulmonary stenosis. The pulmonary stenosis cut பண்ணி விட்டு VSD close பண்ணி விட்டுருவோம். அது வரைக்கும் we have to do a palliative surgery. That also they will ask. So as early as possible within 6 months we have to do. So two-step procedure. First is palliative. This is definitive. Okay. So this is the X-ray of boot-shaped heart. Can we make out this boot-shaped heart? It is also called as scar and sabot, money bag. Okay. So this palliative surgery la enna பண்ணுவோம் அப்படினா pulmonary artery தான் pulmonary stenosis இருக்குல்ல, அதனால pulmonary artery க்கு blood போகாது. So we will connect left subclavian artery to the pulmonary artery. Left subclavian artery எடுத்து pulmonary artery ல connect பண்ணி விட்டுறோம். This is end to side anastomosis is VT shunt, that is Blalock Tausching shunt. End to side anastomosis is Blalock Tausching shunt. Modified BT shunt அப்படினா side to side, இது இந்த சைடுக்கும் connect பண்ணி விட்டோம்னா that is modified BT shunt. We have two more shunts. So we'll draw this diagram as ours. This aorta. Okay. Aorta is left subclavian artery. So left subclavian artery ko pulmonary artery ki connect பண்றது BT shunt. That is Blalock Tausching shunt. We know. Okay. So ascending aorta vyum pulmonary artery connect பண்றோம். Ascending aorta vyum pulmonary artery connect பண்றது வந்து Watterson shunt. Whereas descending aorta vyum pulmonary artery connect பண்ணி விடுறது பேர் வந்து pot shunt. So remember this, one of my friend used to remember it like water in pot. So இது potல மேல வந்து தண்ணி தான் இருக்கும். So மேல இருக்கிறது வந்து ascending aorta. So ascending aortaல Watterson shunt, கீழ இருக்கிறது pot. So pot shunt is for descending aorta. Okay. It is funny but easy to remember. Okay. So these are one-liners you have to remember. Tetralogy of Fallot நமக்கு தெரியும். Pulmonary stenosis, right ventricular hypertrophy, VSD, overriding of fossa aorta. There is something called trialogy of Fallot, which is pulmonary stenosis, right ventricular hypertrophy with ASD instead of VSD. There is something called pentalogy. Tetralogy plus ASD. It is easy. There is something called pink Fallot. What is pink Fallot? Cyanosis varadu. Cyanosis varadu. Yen varadu? Because there will be a mild form of pulmonary stenosis. Okay, mild form of pulmonary stenosis irundhuchna pulmonary artery ki blood போகும். So we won't be getting cyanosis in this scenario. That is pink Fallot. Okay. So other things I will just tell the X-ray findings. Remaining I had given in that material also. You can remember with that. So the typical X-ray findings you have to remember in other cyanotic congenital heart disease. So in Epstein's anomaly, we will be getting this big cardiomegaly. It is called as box-shaped heart. So box-shaped heart is there in Epstein's anomaly. In TGA, what is TGA? That is transposition of great arteries. Aorta pulmonary artery, pulmonary artery aorta. So in that we will be getting egg on string appearance. So this is egg on string appearance, which is specific of TGA, transposition of great arteries. Okay. Next, truncus arteriosus specific TAPVC. What is TAPVC? TAPVC is total anomalous pulmonary venous connection. So total anomalous pulmonary venous connection X-ray finding is figure of 8. So this is figure of 8 or snowman appearance. So figure of 8 or snowman appearance is in TAPVC. Okay. So this is the last flow chart we have to remember. Last table we have to remember. CCHD with decreased pulmonary blood flow, CCHD with increased pulmonary blood flow. So in the pathophysiology in the one liner, easy answer. Okay, this table I had given. This is the same thing what we saw. Decreased flow and increased flow. Okay. So the next topic what we are going to see is CNS. So CNS CSF secretion So CNS mainly they will ask question from hydrocephalus and few seizure disorders they will ask. So hydrocephalus the hydrocephalus cause it can be acquired or it can be congenital. Okay. So congenital hydrocephalus is always most commonly it is non-communicating. It is obstructive hydrocephalus. Whereas acquired hydrocephalus communicating hydrocephalus. So the most common cause of communicating hydrocephalus is subarachnoid hemorrhage. The most common cause of communicating hydrocephalus is subarachnoid hemorrhage, followed by meningitis. Whereas the most common cause of non-communicating hydrocephalus is aqueductal stenosis, followed by the malformations, Arnold-Chiari malformation and Dandy-Walker malformation. Okay. So this we have to remember. The most commons will be most expected in the exam. So Arnold-Chiari, Dandy-Walker common findings we'll see. Arnold-Chiari will be having a flat occiput, whereas Dandy-Walker will be having a prominent occiput. So the hydrocephalus will be more prominent in Dandy-Walker than compared to that of Arnold-Chiari. Okay. So Arnold-Chiari we have two types, type 1 and type 2, whereas Dandy-Walker we have 4 types, 1, 2, 3, 4. Arnold-Chiari type 1 Arnold-Chiari type 1 is more common in adolescents and adults. Okay. So age group Arnold-Chiari Dandy-Walker type 1 and type 2 So Arnold-Chiari type 1 is more common in adolescents and adults. It is due to herniation of cerebellar tonsils into cervical canal. So remember, there is no hydrocephalus in this malformation. So no hydrocephalus in Arnold-Chiari type 1. It will be usually associated with syringomyelia and encephalocele. Syringomyelia cystin spinal cord. Spinal cord cystin is syringomyelia. So usually this type 1 is associated with no hydrocephalus and syringomyelia and encephalocele. Type 2 age group is infancy. Okay, type 2 age group is infancy. There will be a progressive hydrocephalus. There will be a progressive, very big hydrocephalus, and usually it will be associated with the lumbar type of meningomyelocele. So associations age hydrocephalus type. So it is more common in infancy, progressive hydrocephalus, meningomyelocele type of lumbar type of meningomyelocele association. Okay. Sorry. Dandy-Walker again, it is more common in childhood. Dandy-Walker is more common in infancy than childhood. 90% again it will be associated with hydrocephalus and with association of corpus callosal age and cervical type of meningomyelocele. Okay, cervical type of meningomyelocele. So this finishes a very basic differentiation between Arnold-Chiari and Dandy-Walker, which is the second most common cause of congenital type of hydrocephalus. Okay. So next things will be in scenarios. We'll cover all the salient points in this scenario only. So it is a school-going female child. School-going or 5 to 15 years fuller female child. with poor school performance, a brief state of staring episodes associated with blinking and uprolling, precipitated by hyperventilation. Precipitated by hyperventilation. You can answer if you look. Precipitated by hyperventilation. There is no false or post-ictal confusions, and EEG is showing typical 3H slow wave pattern, 3H spike and slow wave pattern with some Rolandic spikes. So in the 3H pattern, is a specific EEG finding. So what is the diagnosis? Sorry. So the answer here is absent seizure. So absent seizure order typical description is this. So you can find out with the absent seizure with this scenario. And it is very good prognosis. It will go for spontaneous remission in 12 years. Okay. And the second thing is a child is having myoclonic jerk. Myoclonic jerk, adolescent boy, early morning presentation. He is alcoholic, sleep deprived, 4 to 5 Hz spike and slow wave pattern. So what is the syndrome? It is JME, that is juvenile myoclonic epilepsy. It is also called as Jan's syndrome. It is also called as Jan's syndrome. Okay. So it is again of good prognosis. Sorry. The drug of choice here is valproate and lamotrigine. So this is the second thing we have to remember. JME, Jan's syndrome. The third is the child, 6 months old child. So infant, usually infant presentation with neuroregression. Neuroregression na milestones achieve item, marudiya milestones la loss avudu. Okay. So with the symmetrical contractions of body muscles, flexion of hip and neck. So it is called as thalam spasms. It is called as thalam spasms. So thalam spasms with hips arrhythmic pattern of EEG. Hips arrhythmic pattern of EEG vandichu appadina the specific is infantile spasm. It is also called as West syndrome. It is also called as West syndrome. The syndrome name alla kekradhukku nariya chance irukku. Remember these names. Okay. So it is called as West syndrome. It is very poor prognosis. The treatment of choice is ACTH. The treatment of choice is ACTH. In tuberous sclerosis condition, there can be presentation of infantile spasm. The treatment on tuberous sclerosis is vigabatrin. Okay. Focal okay. Febrile seizures. Sorry, I have put the answer. So a 1.5-year-old child. So the age group is 5 months. Age group is 5 months to 5 years. Male child with the fever of 38 degrees Celsius, the severe pallor associated with iron deficiency anemia, with the family history of convulsions. So all these are salient points here. The convulsion is GTCS type, lasts for less than 10 minutes. But there is no other evidence of CNS involvement. CNS infection or trauma or metabolic derangement. So edume irukkodadu. Verum fever. 5 months to 5 years of age group with a strong family history. Always think of febrile seizures. Okay. These febrile seizures usually will not go for any recurrence within 24 hours. That is simple febrile seizures. If there is any recurrence, we will call it as complex febrile seizures. Okay. Usually CT, MRI, EEG, and the investigation it will settle on its own. So simple febrile seizures, prophylaxis we can give benzodiazepine. Whenever the fever is there, we can give clobazam benzodiazepine for prophylaxis. Whereas continuous prophylaxis, phenobarbital or valproate. Paracetamol, can we give paracetamol for prophylaxis? Fever no, there is no role of prophylactic paracetamol in the case of febrile seizures. Okay. So status epilepticus protocol, very basic, we'll remember. Status epilepticus, any convulsion lasting for more than 5 minutes is status epilepticus. First step, airway breathing circulation check. Second, we have to give benzodiazepine, preferably lorazepam or midazepam we have to give. First. Second, we have to load with phosphatidyne. Phosphatidyne, we can give phenytoin. Phosphatidyne kaduthu, we have to give barbiturate, phenobarbital. So here, if it is a focal seizure, we can go for sodium valproate. If it is a focal seizure, we can go for sodium valproate. If a standard anticonvulsant kuduttom. So this is initial standard anticonvulsant kuduttu koraila appadina, it is called as refractory status epilepticus. So this terminology we have to remember. Refractory status epilepticus. Then we have to consider for IV anesthetics. IV anesthetics kuduthum koraila appadina, it is called a super refractory status epilepticus. Okay. So this finishes the very basic CNS. The EEG patterns also I have given the same thing what we saw. 1 to 2 Hz spike and slow wave pattern is LGS. That is Lennox-Gastaut syndrome. 3 Hz spike நம்ம பார்த்தோம். 3 is absent seizures. 4 Hz 4 to 5 is Jan's syndrome. Hypsarrhythmic pattern நம்ம பார்த்தோம். West syndrome. Spike and wave followed by immediate slow. That is called as atonic seizures. Okay. So these are all the typical EEG patterns we have to remember. So அடுத்து RSல ஒரு 2-3 important questions மட்டும் பார்த்தறலாம். One is congenital diaphragmatic hernia. We have 2 types, right-sided hernia, left-sided hernia. Right-sided hernia is called as Morgagnian hernia. Morgan spelling may not be correct. Morgagnian hernia. Left is called as Borsdolak hernia. Okay. So remember, right side la நமக்கு liver இருக்கு. So liver இருக்கிறதுனால மார்கேக் இது வந்து வெறும் small defect தான் இருக்கும். So defect இருந்துச்சுனாலும் liver வந்து அதை க்ளோஸ் பண்ணிக்கும். So there is a small defect, good prognosis. Okay. இது வந்து very large defect. இது வந்து very large defect. ரெண்டாவது லெஃப்ட்ல வந்து we know don't have any organ to close. So எல்லா total bowel contentமே thoracic cavity குள்ள வந்துரும். So it is of bad prognosis. So இது small defect அப்படின்னா this is retrosternal anterior. இது வந்து large defect அப்படிங்கிறது வந்து posterior lateral sideல இருக்கும். Posterior lateral side. Okay. So only this much if you are remembering, that is enough. Morgagnian hernia, Borsdolak hernia, small, large, good prognosis, bad prognosis. Okay. So what are the complications we'll get in? Usually we use presentation. Usually it will present with gurgling sound. Gurgling sound. We have seen the scenario in newborn, right? Gurgling sound in the thoracic cavity. Heart sounds on the opposite side push ஆயிருக்கும். The baby will be having a respiratory distress. Okay. So this will be the presentation. And remember, we should not do no bag and mask ventilation in the case of congenital diaphragmatic hernia. No bag and mask ventilation because all the bowel content is in lungs. If we do bag and mask, the lungs will expand and it will burst. We will go for pneumothorax. So we should not do bag and mask ventilation in congenital diaphragmatic hernia. So this is the investigation of choice is chest X-ray. We will be having a typical bowel contents in the thoracic cavity. So this is left-sided Borsdolak hernia. Okay. Treatment, we have to do a surgical repair, subcostal approach. Subcostal approach. Chinnada irundhuchu appadina, if it is less than 2 mm appadina, we can close with the native tissue. If it is more than 2 mm appadina, we should use the artificial Koncpt patch. We can use this patch to close this congenital diaphragmatic hernia. Okay. We are speaking for so long time. Can anyone answer this question? Which type of tracheoesophageal fistula is this? What is the type of tracheoesophageal fistula?
B, sir.
B, sir. Are you sure, madam?
C.
D.
C, sir.
D.
C.
C. Okay, it's not C. I'll give a clue. Which type of tracheoesophageal fistula will not have gas shadow in the stomach? This is tracheoesophageal fistula. Can you make out that in X-ray? Because there is a coiling of NG tube. Can you see this? This NG tube is not coming down. It is coiled here. That is tracheoesophageal fistula. Sorry, excuse me. I'm getting a call. Yeah, you can try now. So this is tracheoesophageal fistula because of coiling of this NG tube here. Okay. So we'll see the finding. We'll see it. So we have types of tracheoesophageal fistula. We all know we have 5 types of tracheoesophageal fistula. So let us draw this like this is esophagus, stomach. There is a disconnection here. And this is trachea. Okay. So this is esophageal atresia. Remember, all tracheoesophageal fistula will be invariably associated with the esophageal atresia. So esophageal atresia will be there in all type of tracheoesophageal fistula except type E. So we have 5 types A, B, C, D, E. Except type E, எல்லாத்துலயும் esophageal atresia இருக்கும். இந்த end blunt தான் இருக்கும். Okay, ஒன்னு. Second, remember type A la there is no fistula. Type A la fistula இருக்காது. It is only esophageal atresia. Type E la there is no atresia. There is no atresia, only fistula. So this is also called as H type. This is also called as H type of tracheoesophageal fistula. இதெல்லாம் கேட்பானுங்க. Type E என்ன type அப்படின்னா H type tracheoesophageal fistula. Okay. So remaining இருக்கிறது 3 தான். இந்த 3ல the most common type is type T. Maybe you have chosen type T because of that reason, I think. So most common is type T. Yes. Okay. So type B, C, D தான் அடுத்து இருக்கிறது. So we will be having fistula. So type B la we will be having proximal fistula. Type C la we will be having distal fistula. Type D la we will be having both proximal and distal fistula. Okay. It is easy, right? So type B la proximal fistula தான் இருக்கும். Type C la distal end of proximal na இது esophagus ஓட proximal end la attach ஆயிருக்கும். Distal fistula na esophagus ஓட distal end la attach ஆயிருக்கும். D la வந்து both proximal and distal end la attach ஆயிருக்கும். Okay வா? So can we get gas shadow here? A. Because there is no connection of trachea la இருந்து தான் காத்து வரணும். இந்த esophagus ல தான் வரணும். ரெண்டுமே இங்க ஜாயிண்ட் கிடையாது. There is no gas. Okay. இங்க no gas. Okay. But இங்க connection இருக்கு. So we'll be getting gas here. Here also connection is there. We'll be getting gas here. Here also connection is there. We'll be getting gas here. So no gas shadow in stomach in type A and type B. Okay. So we can find out which type it is. So associations of tracheoesophageal fistula, we have Vactral association and charge association. Charge syndrome associations will be there in tracheoesophageal fistula. Presentation, usually it will present with respiratory distress at birth and continuous frothing from mouth. Okay, because this blunt end of esophageal atresia will be keep on secreting secretions. So this will be coming as a frothing from the mouth with respiratory distress of type A, B, C, D. The H type இருக்குல்ல இது மட்டும் at birth present ஆகாது because it is H type. So later when the baby started feeding, micro aspirations ஆகும். அதாவது esophagus ல இருந்து lungs க்கு போகும். It will present with recurrent respiratory tract infection after 1 month of life. So இது ஒண்ணு மட்டும் லேட்டா தான் present ஆகும். மத்த எல்லாமே at birth with respiratory distress present ஆயிரும். Next investigation of choice is X-ray. Okay, X-ray la what we can see, there will be coiling of NG tube. The coil தெரியுதா? The coiling of NG tube will be there. So atresia-னால அது அப்படியே வெளியே போயிரும் வளைஞ்சு. So here this is coiling of NG tube. But can we see there is no gas shadow here? So but there is gas shadow here. So this can be type A or B. This can be type ABC. Sorry, this can be type C, D, E. It can't be E also because E la tube கீழ வந்துரும். So it can be C or D. Okay. So it is easy. So we finished tracheoesophageal fistula. Treatment we have to do a surgical connection. If it is a less than 3 mm, if it is less than 3 centimeter, we can create a neo-esophagus. We can pull the esophagus and do anastomosis. We can pull and do anastomosis. If it is more than 3 mm, we have to create a neo-esophagus. Okay. So the answer here is B. So few rapid fire questions you can tell. The most common cause of respiratory distress in preterm baby. This we saw. Yes, it is RDS. Right. RDS or hyaline membrane disease, both are same.
Transient tachypnea.
Yes, it is correct answer. Postpartum baby.
Meconium aspiration syndrome.
Meconium aspiration syndrome. Very good. So next is most common cause of stridor. What is the most common cause of stridor in newborn baby?
Aspiration.
Actually, the answer is laryngomalacia.
Okay, sir.
It is the weak larynx, laryngomalacia. Acute onset stridor. Most common cause of acute onset stridor in, yes, sorry, answer is foreign body. It's right. Most common cause of post-infectious stridor.
Croup.
It is ALTB. Yes, right. ALTB, acute laryngotracheobronchitis or croup. So next we'll see some questions on stridor. Stridor la laryngomalacia. So laryngomalacia la enna kepanga. So this is normal larynx, normal airway. Laryngomalacia la enna avuna in the structures alla romba weak ah irukum. So we'll be having a floppy structures that will form the omega shape epiglottis. Omega na is the omega. So this will form an omega shape epiglottis. Can we see this? This will form an omega shape epiglottis. So that is laryngomalacia. Actually, it does not require any treatment. When the baby start growing, that voice box will get develop and it will mature to form a normal structure. So laryngomalacia the baby will be having a very scary stridor, but it is no need to worry. Okay. So the second difference what we have to read is croup and epiglottitis. Croup is acute laryngotracheobronchitis. Croup is acute laryngotracheobronchitis. The organism for croup is parainfluenza, whereas epiglottitis it is bacterial infection. It is streptococcus and staphylococcal infection. Clinical features of croup, it will present with URI and the child will be having a very barking cough. A typical barking cough will be there in croup. URI la or mild fever da irukum. Epiglottitis la vandu URI irukadu. The child will be toxic child, high fever, not taking feeds, very sick child da irukum. Epiglottitis because it is bacterial infection. Okay. So idhula nyabam vechukka indha group la vandu there won't be any drooling of saliva, whereas epiglottitis la continuous drooling of saliva irukum and the child will be in tripod position. Nadula kai vechi tripod position la ukandittu irukum because it will be having breathing difficulty also. Okay. So X-ray, typical X-ray finding in croup, we will be getting a church steeple sign in croup. Epiglottitis we will be getting a thumb sign. Epiglottitis we will be getting a thumb sign. Treatment for croup, steroids, nebulization, heliox, and there is no role of antibiotic because it is a viral infection. There is no role of antibiotics. Epiglottitis we have to give antibiotics. Okay, so this difference we have to know. So ALTB la vara X-ray this is church steeple sign and this is thumb sign.
ALTB ne enna?
ALTB na acute laryngotracheobronchitis. Larynx, trachea, bronchi ellame involve agum. That is acute laryngotracheobronchitis. This other name for croup. Okay. So church steeple sign and thumb sign. So few most common questions will read and will finish RS here. So most common respiratory infection, URI. Most common respiratory infection is URI. As of now, book la irukra most common virus vandu rhinovirus. But we don't know, it may have changed to coronavirus. Still books are not updated. Okay. The second most common LRI, viral or bacterial? It is viral. Again, viral pneumonia. Second is bacterial. So most common respiratory infection is viral. That URI irundhalum seri, LRI irundhalum seri. Okay. Most common LRI is pneumonia. That is also viral pneumonia. Okay. So most common in infancy, it is viral pneumonia. So viral LRI, that is bronchiolitis. Bronchiolitis caused by most common organism here, RSV. Respiratory syncytial virus is the most common organism. Bacterial pneumonia vandu வரலாம், that is second most common. இது வந்து ஏஜ் குரூப் வச்சு the organism will differ. Okay, less than 3 weeks baby la bacterial pneumonia na it is E. coli. GBS is group B streptococcus. which is the normal flora in the normal vaginal flora. Remember, E. coli pneumonia is most common in 3 weeks. 3 weeks to 4 years la pneumococcal pneumonia. Adanalada we are covering it with, actually previously it was Haemophilus influenza, which is Haemophilus influenza B, which has come down very grossly. It has come down because of vaccination. Now the present culprit is pneumococcus, and we have started giving pneumococcal vaccination in government itself for pneumonia. Okay. After 4 years, it is atypical organism. The most common organism is Mycoplasma and Chlamydia. Okay. So we'll finish this. Recurrent respiratory tract infection apna enadhu? More than 6 respiratory infections in 1 year. It can be URI, it can be LRI, otitis, pharyngitis, more than 6 infections in 1 year. We can tell it as recurrent respiratory tract infection. Okay. Recurrent pneumonia, more than 2 episodes of LRI. More than 2 episodes of LRI in 1 year, or more than 3 episodes in lifetime. ஒரு வருஷத்துல ரெண்டு pneumonia இல்ல லைஃப் டைம்ல 3 pneumonia வந்துருச்சுனால it is recurrent pneumonia. Okay. With the X-ray clearance in between, usually X-ray clearance will take 2 to 4 weeks to go. Persistent pneumonia, the symptoms and the X-ray finding persist after 4 weeks of treatment. 4 வாரம் ட்ரீட் பண்ணதுக்கு அப்புறமேட்டு இந்த pneumonia persistingனா it is persistent pneumonia. Persistent diarrhea na more than 2 weeks. Persistent pneumonia na more than 4 weeks. இதெல்லாம் ஞாபகம் வச்சுக்கோங்க. Okay, so WHO classification of pneumonia, revised guidelines. Previously it was no pneumonia, pneumonia, very severe pneumonia, and very severe pneumonia. Now it is changed to only 3. No pneumonia, pneumonia, severe pneumonia. No pneumonia abdina cough, cold, fever. That is no pneumonia, only URI. Okay. Pneumonia abdina cough, cold, fever with fast breathing or chest in drawing. With hurried breathing or chest in drawing, it is pneumonia. Severe pneumonia na idella. Cough, cold, fever, fast breathing, chest in drawing, plus danger signs of pneumonia. Danger signs na enna varkalam? Lethargic, cyanosis, convulsions, because of hypoxia. Complications of hypoxia. It is severe pneumonia. No pneumonia ku home treatment, symptomatic management. Pneumonia ku we have to treat with oral antibiotic. The drug of choice for first line is amoxicillin, oral amoxicillin. Severe pneumonia admit pannanum. The first line is ampicillin and gentamicin. Second line is ceftriaxone. Okay. First line is ampicillin, gentamicin. Second line is ceftriaxone. Avlo ஞாபகம் podum. HIV இருந்துச்சுனாலும் same regimen தான். Pneumocystis 0VC suspect பண்ணா மட்டும் we can give Cotrimox. Okay. So this finishes RS. These are all few scenarios I had given in the material also. You can go through with that. Common things what we have to brush before going to exam. Bronchiectasis you should know. Rhinosinusitis you should know. Bronchiolitis obliterans you should know. Cystic fibrosis you should know. TP, tropical pulmonary eosinophilia. ABPA is allergic bronchopulmonary aspergillosis. So few values also will be there. I had given it as a table in that material. So you can go through the same things in that because we are running out of time here. Okay. So the next topic what we are going to see is adrenal. So this again a favorite topic in all exams. Congenital adrenal hyperplasia. Only adrenal. Okay. So hypothalamus la corticotropin releasing hormone secrete out CRH. This will go and act in pituitary. Pituitary la enna varum? ACTH varum. ACTH innur per irukku. It is also called as melanocortin. So melanocortin. Okay. So this ACTH will go and act in adrenals. That we all know. But it is also called as melanocortin, right? So it has to go and act in melanocyte also. So melanocyte la MC1 receptors, melanocortin 1 receptors irukum. Anga poi act ஆகி it will help in the synthesis of melanin. So அதனால தான் ACTH அதிகமா இருக்கிறதுனால hyperpigmentation of body, hand, face இதெல்லாம் வருது இல்ல. That is because of this melanocortin activity in the melanocyte, ACTH activity in the melanocyte. Okay. Adrenalலையும் அதே receptor தான் இருக்கு. That is MC2 receptor, melanocortin 2 receptors in adrenals. So அங்க வந்து this melanocortin will go act and help in the uptake of fat, uptake of cholesterol for the synthesis of hormones. Okay. So இது very basic. So disorders of adrenal gland வந்து adrenal insufficiency மட்டும் நம்ம பார்க்க போறோம். Adrenal insufficiency இல்ல it can be congenital adrenal insufficiency or acquired adrenal insufficiency. Acquired adrenal insufficiency ல primary secondary ரெண்டு இருக்கு. Primary, the most common primary acquired adrenal insufficiency is Addison's disease. Addison's disease ஓட most common cause வந்து TB. In India it is TB. In Western countries it is autoimmune. Autoimmune adrenalitis. Okay, இதுலயும் கேட்பாங்க. Addison's disease. Secondary வந்து ACTH deficiency நால. Primary னா adrenal glandலயே பிரச்சனை. Secondary னா அதுக்கு மேல இருக்க லெவல்ல. That is our pituitary லெவல்ல பிரச்சனை. Okay. And remember Addison's அதாவது primary adrenal deficiency ல பிரச்சனை அப்படின்னா ACTH என்னவும் அதிகமாகும். இங்க ACTH ரொம்ப அதிகமா தான் இருக்கும். So ACTH அதிகமாயிட்டே இருந்துச்சுன்னா hyperpigmentation வரும். Whereas secondary adrenal insufficiency ல ACTH கம்மியா இருக்கும். So there is no hyperpigmentation in secondary adrenal insufficiency. This difference you have to remember when you are reading this. Okay. So the next is congenital adrenal hyperplasia. இதுக்கு வந்து flow chart தெரிஞ்சிருக்கணும். Then only we can remember this. This flow chart is available in all books. We have to memorize this chart. We'll memorize this easily. Okay. Cholesterol ல இருந்து first pregnenolone வரும். Pregnenolone ல இருந்து progesterone வரும். இதுக்கு தேவையான என்சைம் வந்து 3-beta hydroxysteroid dehydrogenase. 3-beta HSD hydroxysteroid dehydrogenase. Progesteroneல இருந்து 11-deoxycorticosterone 11-deoxycorticosterone வரும். அதுக்கு தேவையான என்சைம் வந்து 21 hydroxylase. 11-deoxycorticosterone ல இருந்து corticosterone வந்துரும். corticosterone ல இருந்து 18 hydroxycorticosterone வரும். அதுக்கு வந்து aldosterone வந்துரும். Okay. So this chart let us go this chart. How to remember this enzyme will tell you. So pregnenolone ல இருந்து 17 alpha hydroxypregnenolone வரும். அதுக்கு தேவையானது வந்து 17 hydroxylase. OH is hydroxylase. So 17 hydroxypregnenolone வந்து 17 hydroxyprogesterone. So here it is pregnenolone, here it is pregnenolone, here it is progesterone, here it is progesterone. Okay. This enzyme is same again. 17 OH தான். So இதுக்கப்புறம் எல்லா enzyme அதே தான் வரும். The steps will be same. இங்க 3-beta steroid dehydrogenase, இங்க அதே 3-beta hydroxysteroid dehydrogenase தான். 11-deoxycortisol, cortisol. Okay. So 17 hydroxyprogesterone வந்து DHEA, dihydroxyandrostenedione. So DHEA வரும். DHEA ல இருந்து androstenedione, androstenedione ல இருந்து testosterone. Okay, testosterone வந்து active form of testosterone is DHT. So this is 5-alpha reductase. So how to remember this enzyme? You remember, okay. So aldosterone. So we have 3 important set of hormones here. One is aldosterone. Aldosterone is responsible for salt regulation. Cortisol is responsible for speed regulation. And dihydrotestosterone is responsible for sex hormone regulation. Okay. So salt, sweet, sex. இது மூணு மட்டும் தான் நம்ம வந்து பார்க்க போறோம். So remember these 3 enzymes as 3-2-1. Okay, 3-beta hydroxysteroid dehydrogenase, 21 hydroxylase, 11-beta hydroxysteroid dehydrogenase. 3-2-1. அதுக்கப்புறம் 17-18 இது ரெண்டு மட்டும் ஞாபகம் வச்சிட்டீங்கன்னா போதும். மத்தெல்லாம் தேவையே இல்லை. So remember only this 3-beta, 21, 11, 18, 17. அவ்வளவுதான். Okay. So what are the functions தெரிஞ்சுன்னா நம்ம சயின்ஸ் படிக்கிறதுக்கு ஈஸியா இருக்கும். So aldosteroneோட ஃபங்க்ஷன் என்ன? What is the function of aldosterone? So this is digital convoluted tubule. சோடியமும் குளோரைடும் ரீஅப்சார்ப் பண்ணுது, வாட்டரையும் ரீஅப்சார்ப் பண்ணுது, பொட்டாசியமையும் H+யும் செக்ரீட் பண்ணி விடுது, அதாவது வெளியே அனுப்புது. It is excreting potassium and H+ and it is absorbing sodium and water. Okay, this is the function of aldosterone. Sodium and water reabsorption, potassium and H+ secretion. Okay. So aldosterone கம்மியா இருக்கு அப்படின்னா என்ன ஆகும்? ஹைப்போஆல்டோஸ்டெரோன்ல என்ன ஆகும்? சோடியம் ரீஅப்சார்ப் ஆகாது, சோடியம் என்ன ஆகும்? வெளியே போகும். ஸோ என்ன ஆகும்? ஹைப்போநெட்ரீமியா ஆகும், வாட்டர் வெளியே போகும், அதனால ஹைப்போடென்ஷன் ஆகும், ஹைப்பர்கெலிமியா ஆகும், பொட்டாசியமும் H+ம் செக்ரீட் ஆகாம பாடிக்குள்ளே இருந்துக்கும், அதனால ஹைப்பர்கெலிமியா ஆகும், H+ இருக்கிறதுனால மெட்டபாலிக் அசிடோசிஸ் ஆகும். ஸோ ஆல்டோஸ்டெரோன் டெஃபிஷியன்சி ஆச்சு அப்படின்னா these features we will get. Okay. So second is sweet, that is our cortisol. Cortisol is also called as stress hormone. It will secrete only during stress, flight, fight hormone. Okay. So stress hormone. இதோட வேலை என்ன அப்படின்னா it will increase the availability of blood glucose for the immediate use. Second is it will increase the BP and heart rate during the stress. Okay. So if cortisol கம்மியா இருந்தா என்ன ஆகும்? Bioavailability of glucose தான் அதிகப்படுத்துது. So here we will get hypoglycemia. Again BP heart rate குறைஞ்சுனா we will get hypotension. So because of that we will be having fatigue, weakness, tiredness இதெல்லாம் வந்துரும். ஓகேவா? So this will cause cortisol. The last is sex hormone. Sex hormone we should know these two terminologies: true hermaphrodite, pseudo hermaphrodite. True hermaphrodite அப்படின்னா ovary இருக்கும், testis இருக்கும். So both the gonads will be there in the same living thing. That is true hermaphrodite. Pseudo hermaphrodite அப்படின்னா ovary இருக்கும் ஆனா male genitalia இருக்கும், male external genitalia இருக்கும். Testis இருக்கும் ஆனா female external genitalia இருக்கும். So that is pseudo hermaphrodite. Okay. So in congenital adrenal hyperplasia we will be getting pseudo hermaphrodite only. Okay. So next we will see the disease. The most important disease here is 21 hydroxylase deficiency. 21 hydroxylase இல்லாம போயிடுச்சு அப்படின்னா அது கீழே வர எந்த ஸ்டெப்பும் கிடையாது. Aldosterone will be decreased. So aldosterone decrease ஆயிடுச்சுன்னா salt என்ன ஆகும்? Waste ஆகும். There will be salt wasting, hyponatremia. Okay. So இங்கே 21 hydroxylase இருக்காது, cortisol இருக்காது. Cortisol இல்லாதனால என்ன ஆகும்? Hypoglycemia. So these are all the features. So we can easily remember: hyponatremia, hypotension, hyperkalemia, hypoglycemia. முடிஞ்சு 21 hydroxylase ல இதெல்லாம் இருக்கும். So what will happen? All this will be shunting to the last pathway. So இங்க என்ன ஆகும்? testosterone மட்டும் அதிகமாயிரும். Testosterone அதிகமாச்சுன்னா என்ன ஆகும்? Male genitalia, male will be getting precocious puberty, female will be getting virilization. Female will be getting virilization because of testosterone. So female will be a pseudo hermaphrodite here. Okay. So this is called as classic 21 hydroxylase deficiency. This is classic 21 hydroxylase deficiency. And the investigation of choice here is we have to check for the 17 alpha hydroxy progesterone level. 17 alpha hydroxy progesterone level we have to check. So this finishes the 21 hydroxylase deficiency. Non-classic type ஒன்னு இருக்கு. Non-classic type என்ன ஆகும் அப்படின்னா ஆல்டோஸ்டெரோனும் கார்டிசோலும் நார்மலா தான் இருக்கும். ஆல்டோஸ்டெரோனும் கார்டிசோலும் நார்மலா தான் இருக்கும். Whereas only sexual changes will be there similar at of 21 hydroxylase deficiency. That is non-classical type of congenital adrenal hyperplasia. Okay. So இது நான் ஏற்கனவே சொல்லிட்டேன். 17 hydroxy progesterone தான் வந்து investigation of choice for newborn screening to find out the congenital adrenal hyperplasia. This is the most common type, 21 hydroxylase deficiency. Okay. We have two more types. If 11 beta hydroxylase இல்லாம போயிடுச்சுன்னா என்ன ஆகும்? Similar to that of 21 hydroxylase deficiency. ஒரு ஸ்டெப் கீழே. பட் என்ன ஆகும் அப்படின்னா இந்த 11 deoxycorticosterone இருக்குல்ல, 11 deoxycorticosterone இருக்குல்ல, this is enough to cause hypertension. So 21 hydroxylase oda features தான் இருக்கும். Instead of hypotension we will be having hypertension here. That is the only difference here. That is 11 beta hydroxylase deficiency. Last thing is 3 beta hydroxylase deficiency. இது ஈஸி. இது கட் ஆச்சுன்னா எல்லாமே போயிடும். ஆல்டோஸ்டெரோன் கம்மி, இதுவும் கம்மி. Everything is so hyponatremia, hypotension, hyperkalemia. So everything is shunted to the sexual pathway. அப்ப இங்க என்ன ஆகும்? Male genitaliaவும் virilized hypovirilized இருக்கும், female genitaliaவும் virilized இருக்கும். So these 3 beta is the only place both male and female will be affected. Okay. 17 hydroxylase போச்சுன்னா எல்லாமே அவுட், செக்ஷுவல் பாத்வே கிடையாது. only thing is aldosterone மட்டும் ரொம்ப ஹையா இருக்கும். So there is salt retention. அவ்வளவுதான். So here testosterone is decreased, male genitalia will be hypovirilized, female genitalia will be normal. So this I have simplified in a single table which I had given in the material. You can go through with this. So if you know this pathology, it will be easy for you to, if you know this synthesis of aldosterone, cortisol, sex hormones. It is easy to read this pathophysiology behind the table. Okay, so this finishes endocrinology. So a 2-week-old male infant is eating poorly, has repeated emesis, regained his birth weight. On physical examination, he appears dehydrated and noted to have increased pigmentation of the skin and genitalia. In addition, measuring serum electrolytes, which of the following hormones will be most informative? So the screening test is 17-hydroxy progesterone or pregnenolone. 17-hydroxy progesterone we have to do. Okay. So the last thing I want to brush here is vaccines. I had given all the immunization schedule and a few last minute revision points in the regarding vaccinations there. To discuss the few common points, we'll see. Vaccination at birth, we have to give vaccine as soon as possible or within 72 hours of life. By chance, if the child is sick, we have to give within 1 week. Go for this answer as soon as possible or 72 hours or 1 week. It is not a birth dose. Okay. So if you want to give multiple vaccinations in simultaneous administration, if not feasible due to some reasons, we can give within 24 hours. அதாவது ரெண்டு வேக்சினை ஒரே டைம் கொடுக்க முடியல அப்படின்னா ஒரே நாள்ல கொடுத்துடலாம். within 24 hours கொடுத்துடலாம். The recommended age in weeks, இப்போ ஒரு 9 months MMR அப்படின்னு நம்ம படிக்கிறோம்ல, the recommended aging என்னது? It is 9 completed months. Starting of 9 months கிடையாது. It is 9 completed months. Okay. So a combination vaccine versus separate injection. இப்போ இந்த pentavalent இருக்கு. Pentavalent plus IPV போடலாமா இல்ல எல்லாம் சேர்த்து hexavalent ஒரே இன்ஜெக்ஷனா போடலாமா அப்படின்னு கேட்டா combination vaccine is better than separate injections. Okay. A short schedule of varicella. Okay. Normal schedule of varicella வந்து 15 months ல ஒரு டோஸ், next 5 years ல second dose போடுவோம். There is something called short schedule. That is 15 months ல first dose, 3 months gap விட்டு second dose. That is short schedule of varicella. Okay. So if short schedule, if varicella vaccine second dose is not given a short schedule, prefer combination with. Okay. So combination with MMR. So 15 months la we'll give one MMR, right? So MMRV அப்படினு போலாம். MMRV first dose at 15 months, second dose at 5 years of MMRV. So go for combination vaccine. Okay. Okay. When 2 or more live vaccines are not administered on the same day, ரெண்டு live vaccine ஒரே நாள்ல போடல அப்படின்னா ரெண்டு வேக்சினுக்கும் minimum 4 weeks interval இருக்கணும். ரெண்டு வேக்சினுக்கும் minimum 4 weeks interval இருக்கணும். If it is a parenteral or intranasal vaccine. Oral vaccine, OPV live vaccine தான், ரோட்டாவும் live vaccine தான். இதுக்கு 4 weeks gap போடணுமா அப்படின்னா தேவையில்லை. For oral vaccine, this 4 weeks gap is not required. We can give anytime. இன்னைக்கு OPV போட்டு நாளைக்கு ரோட்டா வைரஸ் போடலாம், even if it is live vaccine. Okay. So the interval between live and inactivated vaccine. ஒரு live vaccineக்கும் ஒரு inactivated vaccineக்கும் interval அப்படின்னா anytime. எப்ப வேணா போட்டுக்கலாம். There is no required interval. Okay. The minimum interval between 2 doses of same inactivated vaccine. That is DPT1, DPT2 போறோம்னு வெச்சுக்கோங்க. Pentavalent 1, Pentavalent 2 போறோம்னு வெச்சுக்கோங்க. The minimum interval between 2 doses of same vaccine is 4 weeks. Again. Different inactivated vaccines any interval. So these are all the common practical things we have to remember. Mostly they will ask those questions in MRB. Okay. So vaccine does not administered up to how many days before minimum interval or age. இப்ப ஒரு டேட் கொடுத்து அந்த வேக்சின் அந்த டேட்டுக்கு போடுறதுக்கு ஒரு 3 நாள் முன்னாடி போட்டோம் அப்படின்னா it is valid or not அப்படின்றத கொஸ்டின். Actually 48 hours வரைக்கும் it is valid. 48 hours முன்னாடி போடலாம். அதுக்கு மேல 3 நாளைக்கு முன்னாடியோ 4 நாளைக்கு முன்னாடியோ போட்டா it is not considered as valid. If recommended intervals are not maintained, just follow schedule. அதாவது no need to restart. ஒன்னு மிஸ் ஆயிருச்சு அப்படின்னா முதல்ல நான் எல்லா கோட்டையும் அழிச்சு ஃபர்ஸ்ட்ல இருந்து போடுறேன் அப்படிங்கிற மாதிரி தேவையில்லை. We have to just follow the schedule. That is enough. So if you miss 15 months booster dose for MMR 9 months la போட்டாச்சு, 15 months la rendavathu dose podala. Now the child has come to you on 5 years, give the direct 5 years dose. That second dose of 15 months dose is not required. Okay. So maximum number of antigen can be given on the same day. N number of antigens can be given. Different vaccines can be mixed in the same syringe. No. 2 different vaccines should not be mixed in the same syringe. Okay. Vaccines for splenectomy. We all know encapsulated organisms. Haemophilus influenza B, pneumococcal, meningococcal, influenza, varicella. So all these we have to give for a splenectomy patient. If we are taking for an emergency splenectomy patient before 2 weeks, planned splenectomy apna 2 weeks முன்னாடியே இந்த vaccine எல்லாம் போட்டுறணும். So emergency or splenectomy பண்றோம் அப்படினா இந்த vaccine எல்லாம் after 2 weeks the patient போடணும். So these durations are all important. You have to remember. 2 vaccines can be given in the same limb at a single visit. Yes, it can be given. 1 inch gap விட்டு we can give in the same limb. 1 inch gap விட்டு we can give in the same limb. Preferred site for IM injection, it is anterolateral aspect of thigh, anterolateral thigh, because the muscle bulk in the children is more in thigh than compared to gluteus. Okay. If BCG scar is absent, but there is evidence of vaccination. கார்ல வந்து BCG போட்டிருக்குன்னு எழுதி இருக்கு, but BCG scar இல்ல. Consider it is given. Okay, we don't need to give BCG again to that patient. Vaccination in individual with acute febrile illness more than 38 degrees Celsius மேல fever இருக்கு அப்படின்னா postpone vaccination, because vaccines can cause fever. அந்த fever வந்து வேக்சின்னாலயா இல்ல previous febrile illness-னாலயா நமக்கு தெரியாது. அதனால we have to postpone the vaccination. So this finishes the rapid revision. I think I have completed most of the things. If you have any queries, you can put it in the group. We can discuss it there. We started the class late, so we finished half an hour late. We started half an hour late and we finished half an hour late. I think I am on my time. Okay. Thank you.
Thank you so much, sir.
Thank you.
Sir,